5, 4, 3, 2, 1.
Good evening, everyone. Hi, everyone. So today we are here for a pancreatic cancer awareness. So November is a month of empowerment, education, and inspiration for communities far and wide who have been touched by pancreatic cancer. Now, it is our opportunity to shine light on this disease, to elevate our voices, to raise awareness, and invite others to answer our call to action. So it's time to educate the world. I'm Dr. Shilpa Daniel, and we have amongst us Dr. Bhavna Sirohi. On the occasion of World Pancreatic Cancer Day, I would like to introduce, she's the consultant medical oncologist, GI and breast cancer, currently the lead medical oncologist in Apollo Proton Cancer Center, Chennai. Now, she's an honorary consultant with the Queen's Mary University, London, was previously working at the Barts Health NHS Trust, London. She started her oncology training in India in 1994 at the Tata Memorial Centre, Mumbai, and completed at Royal Marsden NHS Foundation Trust, UK. When it comes to publications, she has more than 100 papers in national and international journals and lectured worldwide. She has edited 3 books on cancer, Cancer Questions Answered, Chemotherapy in GI Cancers, and Modern GI Oncology. She's the immediate past editor-in-chief of Indian Journal of Medical and Pediatric Oncology. She's the immediate past president of the oncology section of the Royal Society of Medicine and has been involved in the multiple clinical trials, phase 1 to 3, during her career. Also, there are a lot of awards for this leading medical oncologist. She has received the Royal Marsden Award for Excellence in 2000 for enhancing trust's reputation, the TMC Women's Cancer Initiative Award in 2011, LBF Visionary Award for Excellence in 2011, Maulana Ilyasi Jamil Award in August 2013, and Adi Abadi Women Achievers Award in 2014, and Bart's Heroes Award for Education in 2018. And I'm sure, ma'am, in the coming years, we can see upcoming more awards for you in your name. So thank you so much for being here today, this evening. And let's directly move on to the topic. And I would probably hit you a few questions. And it would be great for all of the audience to know more about pancreatic cancer. So moving on, how common is pancreatic cancer in India? And what do you think are the survival rates for patients suffering from pancreatic cancer?
Thank you, Dr. Shilpa, and thank you to AstraZeneca for organizing this, because I think patient education, patient empowerment, and patient awareness is half the battle won, not ignoring your symptoms and going and seeing a doctor. So the incidence, that is new patients with pancreatic cancer, globally is rising. And in fact, there is a 2 to 3-fold increase in incidence of pancreatic cancer, mainly due to lifestyle factors, which we can talk about later. It is the 4th leading cause of cancer death. In fact, in Europe, the statistics which are more robust, it said that it will take over breast cancer as the leading cause of cancer-related deaths. As far as India is concerned, the incidence of pancreatic cancer is about 2 per 100,000 population. Compared to the West, where is 8 per 100,000. So the number of patients, the new patients is less, but because of the sheer volume of our population, the numbers are more. Also, I must say that we do not have a robust registry. I mean, there's a National Cancer Registry program, but it represents about 10 to 15% of the population. So we don't have the exact numbers. And as far as survival is concerned, I think this is one cancer where we are not doing so well in improving outcomes, though I would say in the last, I started training more than 2 decades ago. So I used to say that the median survival is 3 months, then I used to say it's 6 months, and now, it's gone beyond a year. And in fact, in early patients with pancreatic cancer, the median survival with one of these amazing studies which was done was more than 55 months. So which is, we are doing better, we are getting better, and we are getting better with fantastic research, with collaboration between the academia and the industry, the investigator initiated studies. So 5 year is a benchmark that we normally use. So 5 year is, I would say, in locally in early pancreas cancer is about 20%. But in advanced cancer, it used to be 2 to 5%. It is about 10% now, mainly because of a lot of other strategies, molecular strategies that we are using.
And you were talking about this disease as a deadly disease. So how does this actually pancreatic cancer present?
So I think in the pancreas, it's an organ which is present in our body. It is divided into head, body, and tail. And depending on where the pancreatic cancer is, the symptoms would be different. So if it is the head of the pancreas, the patients would very likely present with the new onset diabetes or jaundice or weight loss. But if it's in the body or tail, patients usually present with back pain. So if anyone, you have a pain which is not getting better and is actually getting worse over a period of time, I would suggest, you do not increase it, do not ignore it, go and see your doctor. So these are the common symptoms. New onset diabetes mellitus is diabetes, which is quite common in India, is also a presentation for patients with pancreas. So this should be, in the background that, we rule that out by a simple ultrasound maybe.
And ma'am, what is the common age group which presents with pancreatic cancer? Is it similar to what we study, or it's different from how you're seeing in your
So
clinic?
usually it's a disease of the advanced age, but I've practiced for a long time, 2 decades in UK, and I practiced for a long time in India as well. So because of our population matrix, the patients present a decade earlier in India than they would in the West. So about 30% of patients in the West would be less than 60 years of age. I would say it would be about 50% would be less than 60 years of age in India. In fact, majority of my patients that are currently on chemotherapy or on treatment are very young. Some of them are in their 30s, 40s, and or 50s as well. But usually the median age of presentation is 65 to 70 in the West.
So ma'am, as always, are there any risk factors, specific risk factors for developing pancreatic cancer?
Yes, I think again with a lot of research, we found out that people who have a high body mass index, or people who are obese or have diabetes or use tobacco, they are at a higher risk of developing breast cancer. In fact, in Europe, there was this study where they looked at people who had what we call a high health lifestyle index. And that includes smoking, alcohol, exercise, that is activity, diet, and weight. So those who had a higher healthy lifestyle index, so this is a lifestyle disease, that's why it is rising globally 2 to 3-fold. So if you do all of these, the the likelihood of you developing pancreatic cancer is less. So I would say maintain a healthy weight, and also the other risk factor is family history. So if you have a close first degree or a second degree relative who's died of pancreatic cancer, or even breast cancer, ovarian cancer, and prostate cancer, the gene is the same. So you are likely to develop pancreatic cancer. So know your family history. That is very important.
So ma'am, as you said, it's a lifestyle disease. So modifying lifestyle. So do you think those are the common ways to reduce it, or any other things also can be how to reduce these risk factors?
So I think to reduce would be, I always talk about ABCDs of prevention. So A would be avoid tobacco, alcohol. B, if I'm talking about breast cancer, I say be breast aware, breastfeed. But pancreas cancer, I would say, be aware of your symptoms. If there's anything that's not getting better, you see a specialist, especially if it's pain, or if you're losing weight and you don't have a reason why you should be losing weight if you're not trying to lose weight. C is calm, meditation. D is diet. again, a diet is directly linked to your weight gain, and weight gain is directly linked to pancreatic cancer. So maintain a healthy diet, have a rainbow food color diet every day if possible. Ease exercise, physical activity. People who are active are less likelihood to develop any type of cancer. It applies for breast cancer, colon cancer. WHO recommends about 30 minutes of exercise every day. And again, if you have a new onset diabetes, you check it out that you do not have the risk of developing pancreas cancer. F is for family history. Know your family history. S is for screening. Again, screening, there is no recommendation for pancreatic cancer. But there are studies, especially in patients who carry this gene, the BRCA gene, BRCA1 or 2, because 5 to 6% of pancreas cancer patients may also carry this gene. So there are some studies looking at, in breast cancer patients, we recommend doing an MRI of breast. So people are looking into whether, from doing the MRI breast, you take the field down a little bit and do an MRI scan of the pancreas as well, especially if there's a very strong family history of pancreatic cancer.
Ma'am, my next question was this only, that whether there are screening methods, but as you said, there are no screening, but what are the common tests you do for diagnosing pancreatic cancer, or the symptoms when these patients come to you?
So to diagnose pancreas cancer, we would do a staging, a scan, a simple CT scan or an ultrasound of chest, abdomen, and pelvis. We would do, and we also do an endoscopic ultrasound, where we through which we do a biopsy and confirm what type of pancreatic cancer the patient has. It's very important nowadays, I feel, to do a biopsy, because I recently saw a patient who had a pancreatic lymphoma. So it's not as if pancreatic cancer would be a typical adenocarcinoma or pancreatic cancer. It could be a pancreatic neuroendocrine tumor as well, or a neuroendocrine neoplasm, which is no longer rare. That also is rising across the globe. Or it could be a pancreatic lymphoma. So it's very important that we get the histology, the biopsy right, to have an accurate diagnosis, because the treatment for all three of these is completely different.
Okay, that's interesting. Actually, even I never had such a clue about it. Ma'am, you were talking about BRCA gene. So can you throw some more light about the familial aspect to consider in pancreatic cancer, and how important is genetic testing in pancreatic cancer?
So, till about, I would say 2017, we were not doing this. This is quite recent. But now, since 2018, I would say 18, 19, all the guidelines also recommend that any patient with pancreatic cancer, whether it's a newly diagnosed patient who has early pancreatic cancer, or locally advanced or metastatic pancreatic cancer, they should undergo BRCA testing. So the reason why it is important is the germline BRCA testing means that the genes that you carry from your parents. So if you're BRCA positive 1 or 2, then it has implications for your children and your siblings as well, because then they would need to be undergoing genetic counseling and testing as well. But the most important thing is that it has an implication for the patient. If they carry the germline BRCA1, 2, or there are some other genes as well, we call them like PALB2, that's also a genetic marker. So if you have any of these genes, there is a treatment implication, because we have a drug available now called olaparib, which has a significant benefit in patients with advanced pancreatic cancer. So I think any patient with newly diagnosed pancreatic cancer must undergo what I would say a germline mutation testing, because it not only has implications for them, their family, but also on their treatment pathway as well. And about, I would say, 5 to 10% patients with pancreatic cancer would carry the gene.
And ma'am, you're talking about genetic counseling. How important do you think is genetic counseling? I know it's very commonly said term, but how are we actually doing it or practicing?
So, I mean, I struggle. I worked in a country with universal health coverage, so it was very easy for me to refer patients for genetic counseling. But again, also there were time and resource constraints. So I actually did a course. Actually, it was funded by one of the companies with the Royal Marsden, where we learned how to do genetic counseling, because we are, and in India and in any low and middle income group countries, we are short of genetic counselors. So I think it is important that we know the basics of genetic counseling. Each oncologist, in fact, a lot of guidelines, ASCO guidelines also recommend that each oncologist should be trained in how to counsel patients for testing of this. But if the patient becomes positive with BRCA1 or 2, then they should see a specialist for further genetic counseling. Because the reason why I'm able to do it is because I'm able to justify that there is a drug available which is going to benefit them. So it's easy to talk about that. But I think all the pros and cons of genetic counseling need to be discussed, especially with the family members, because it has implications on insurance, in marriage, in having children in the future, whether you're going to pass it on, uh, having discussions about pre-implantation genetic diagnosis. So there are a lot of implications, all of that. The depth needs to be discussed by a genetic counselor.
Sure. Ma'am, moving on to, like, you talked about the risk factors, the diagnosis, and so how is the treatment? What is the treatment regime you follow for the pancreatic cancer patients, and the options available or anything? Just brief.
So I think it depends on the treatment will depend on the stage of pancreas cancer. So in pancreas cancer, we divide patients into an early pancreas cancer, border. So whether it's resectable, whether surgery is possible, then it's resectable, or it is borderline resectable or locally advanced. So then I think even in resectable, all of these I would say is early locally advanced. We are nowadays recommending giving neoadjuvant, like in breast cancer, we give chemotherapy or chemoradiotherapy before surgery. So, and by doing this, I think we have really improved the outcome for our patients. So that is something which is quite new. And I think in the meeting that we have, we're going to have a debate about this in resectable patients, whether they should have chemotherapy before surgery, whether all patients should have it or not. So for the main modality would be surgery. Then you have chemotherapy. You can give it before surgery or you can give it after surgery. The reason we prefer to give it before surgery is because 50 to 60% of patients after pancreatic cancer surgery do not end up having chemotherapy. So, you want to get the treatment sooner rather than later. And if you give it before surgery, almost 100% patients will have it. So surgery, chemotherapy, then you have radiotherapy, which has a role as well to play. And also then you have targeted therapy. Now, there was this amazing network, Know Your Tumor, where I feel molecular testing should be done in all pancreatic cancer patients, because in about up to 50% of patients, they were able to tailor the treatment based on the molecular subtype of the cancer. And in 25% patients, we were able to find drugs which are available. Like, you have, if a patient has a BRCA mutation, you can cisplatin and drugs like olaparib are likely to work better. So, if you have a drug available which can be targeted to that mutation, so I think molecular subtyping has really changed the management, the way we manage patients with pancreatic cancer. The chemotherapy has got better. The chemotherapy regimens have got better, and I think these are the various modalities that you can use for treating pancreas cancer.
So obviously after the treatment, it always comes upon for the patients is like, what are the side effects or the adverse effects? So what are the expected side effects of the different treatment modalities which we give to the patients?
So I'll just talk briefly, like surgery, very, very important that, Whipple's surgery is one of the most complex surgeries in cancer. and it should be done in a center which is doing, at least in UK, they had come up with guidelines that if you're not doing more than 20 Whipples a year, you don't do it. So very important that you find the right surgeon to do this complex surgery. And after surgery also, some patients may need enzyme replacement therapy. They keep losing weight, they're not able to digest their food because bit of the pancreas has been removed, and pancreas actually helps us digest food because it produces the enzymes. So it's very important that you discuss whether you need enzyme replacement therapy after surgery. So I think that's the main thing after surgery. Radiotherapy, it will be related to local side effects, nausea, vomiting, and if any of the organs are closed, depends on which side the radiation is being given, whether it's head, body, or tail of pancreas. Chemotherapy and targeted therapy, I think the effects are general. If chemo acts on dividing cancer cells, acts on normal cells as well, so you have side effects like drop in blood count, which makes you prone to infection, and tiredness is a very common side effect. One of the drugs we use causes tingling and numbness. So these are general side effects. With targeted treatment also, and it's very effective, but you may have side effects like tiredness, drop in hemoglobin. So all of these are, most of these side effects are reversible when we stop the treatment. I think that's the key take-home message.
Sure, ma'am. So, ma'am, after this, what are the chances of recurrence of pancreatic cancer after treatment?
So the chances of recurrence are actually very high after pancreatic cancer treatment. So that's why, I said as oncologists, we always try and look at how long our patients are going to live. So 5-year is a benchmark that we have taken. And like I said, for early pancreas cancer, the 5-year outcomes are about 20 to 30% in the best of hands. And but that's mainly because the recurrences are so high in patients with pancreas cancer. So I would say majority of the patients would recur except about 10 to 20%.
Ma'am, this 2020 is all about the COVID-19 pandemic. So of course, the question, I want to end this talk with this only. So what do you think COVID-19 has actually, how it has affected pancreatic cancer as well, even other cancers as well? How is this pandemic actually affected the treatment for the patients?
I think COVID-19, I'll just go through the lockdowns. When we had the first lockdown in March, so I think between first and second and third lockdown, general cancer screening. I talked about screening. We don't do it for pancreas, but we stopped screening completely. We said, we should not get healthy people to the hospital, and they should stay at home. In fact, a lot of follow-up visits, including patients with pancreas cancer who were coming every 3 monthly, 4 monthly. We said, just let us do a video consult and you don't need to come to the hospital. So that is what we did in the first three lockdowns. But then now, we've realized that this is not going to go away. We have to live with it. We have to do masking. We have to do social distancing. We have to do hand washing. And if we do all of these, and hospitals, I think, have stepped up to the mark and made sure that the places are safe. I think segregation was the key. So we've learned that segregating COVID-19 patients to one center and keeping some centers green has been the key in making sure that you're protecting the other patients. So I think some of the things we've done is video consultation, which has been a huge step forward, because I remember I piloted this in London in 2018, and I had to jump through a lot of hoops. We had to go through the London Digital Collaborative and take this one's consent, that one's consent, and still it hadn't gone through. So because of patient confidentiality, where will you store this? But with COVID, I think that's completely, everybody's forgotten about it. And, video consult has become the norm. The second is, meetings like this. It has democratized education. So, you're able to reach out to a wider population globally, wider audience globally. So education is the positive thing. The third positive thing is, I run a support group meeting every third Monday of the month. So I'm able to have patients from all over India, globe join in as well. So I think, yes, the treatments we changed at the beginning, but right now, I think I look at the positives as well. So these are the positives that have come out.
Thank you so much, ma'am, for this wonderful session we had. Any closing remarks or any take-home messages for all the viewers out there before we go on to the main conference?
So, like I said, just my main message would be that the incidence of pancreas cancer is rising globally. So, it's very, very important that, don't ignore any of your symptoms. And if you have a diagnosis of pancreas cancer, like I said, I'm seeing a lot of patients who've not actually undergone BRCA, the germline mutation testing as well. So, go on various platforms, join a support group, get to know, ask for a second opinion if needed, because, sometimes two heads are better than one. And so that would be my message. Thank you.
Thank you so much, ma'am. So even in this COVID-19, I would just say cancer doesn't distance itself. So
Yeah.
don't wait, contact your doctor, get checked. And thank you so much, Dr. Bhavna, and the organizers as well. So I would like to hand over to Dr. Naresh Somani before we move on to our conference. Maybe any last comments, and then we can.
Do you have any questions from the Facebook?
Right now, I cannot see any questions. Not yet. I guess you covered like all the topics very simplified and clear way. So
Great. Thank you. Thank you for having me. I really enjoyed talking to you.
thank you so much, ma'am. Over to you, for the organizers. Whom should we?
Good evening, everyone. Dr. Bhavna, good evening and welcome.
Good evening, Dr. Naresh. How are you?
Yeah, I'm fine. Good to see you. I think Mr. Tarun from Horizon will be taking over from here, and then we will be starting the meeting.
Great. It's wonderful that you're doing in the Pancreas Cancer Awareness Month.
Yeah.
I think it's very important. Hi, Jay.
Hi, how are you?
Good. How are you?
I'm doing good.
How's Dr. Borges?
She's doing well. She's fine.
Say my hello to her when you
I
see
will.
her.
I will certainly do that.
Yeah, we always talk about her at some or the other meeting, especially when I'm talking to Dr. De Cruz or somebody.
Hey, hi, Dr. Somani. How are you?
I'm fine, sir. Good to see you. Welcome.
Same
Thanks.
here, likewise.
Yeah. As bright as always. Really charming personality.
Yes, absolutely.
So, good evening, Dr. Somani sir. This is Tarun here. Good evening to you, sir. Good evening,
evening.
Jai Mehta sir. Good evening to you.
Yeah, hi, Tarun.
Yeah, hi. So, Somani sir, maybe next 3 minutes, and then I will hand over the floor to you. Sharp 6:30 we'll start, sir.
Yes, we have to be well in the time to start. We have to be well in the time to finish. So once again, I request all the speaker, panelists, and the moderator and everyone, please stick to your time so that we have the enough chance, equal chance to all the speakers, and we can have the more interactions and we finish well in the time.
Sure, sir.
I think all the speakers have joined us.
Yes, sir.
Mr. Tarun, can you see in the participant list? And we
Yes.
have our opening batsman with us, Dr. Jay Mehta.
Yeah. So Dr.
So,
Salesh is just joining.
yeah.
Yeah.
So if our Virat Kohli or our Rohit Sharma, Dr. Jay Mehta is with us, so we need not to worry for the down line, second line or third line.
Exactly. Exactly, sir. Exactly.
So can I start now?
Yes, so namaskar and good evening to everyone. It's a pleasure to welcome you all for this pancreatic cancer update. So to set the ball rolling, it's a pleasure to invite Dr. Naresh Somani, a senior consultant and medical oncology at Bhagwan Mahavir Cancer Research Hospital at Jaipur. To set the ball rolling and the context, over to you, sir, for this evening.
So thanks, Mr. Tarun from the Horizon. And I'm really thankful to you to arrange almost everything for us, and thankful to our both sponsors for the today's meeting, especially AstraZeneca, that they are taking a lot of pains, doing the effort to make the awareness about the pancreatic cancer among the medical fraternity, especially in the oncology community, and to bring on the surface the recent changes which has happened in the field of the pancreatic cancers, and telling us that how we are moving more than chemotherapy, especially in the locally advanced or metastatic setup. So far, we used to have only the chemotherapy armamentarium with us. Now, with the advent of the molecular things and how the things are being manipulated or being utilized, these molecular abnormalities and how they have become the druggable, it's a really good to see the results in our patients. So I'm thankful to AstraZeneca and MedGenome to give this wonderful opportunity. And as we all understand that so many changes, advances has happened in the field of the pancreatic cancer, not only in the medical oncology, in the immuno-oncology field, but in the radiation techniques also, and especially in the field of the surgical oncology also. And today we talk about the neoadjuvant treatment, systemic treatment in the field of the operable pancreatic cancer, something like esophageal malignancy, or let's say in the breast cancer patient, early operable cancer. So we are talking about the neoadjuvant treatment in a field which used to be only the surgical field. So without taking much of the time, let me request the first speaker, Dr. Jay Mehta, well-known figure in the field of the oncopathology. He's from Mumbai. He's at the center of the oncopathology. And we all are dependent on Jay Mehta for a lot of things. And if he has given any diagnosis, that is always taken as the diagnosis. So I welcome Dr. Jay Mehta to throw the light on the recent aspects in the field of the molecular and genetics in the pancreatic malignancy, exocrine pancreatic malignancy. Dr. Jay Mehta, please.
Hi, thank you, Dr. Somani. I'm just trying to share my screen. Yeah, okay. I think I should be able to do it now. Okay, is that visible, the screen?
Yes, sir, your screen is visible and you are audible, sir.
Okay, so I'll start quickly without wasting any time now. Thank you, Dr. Somani, for the kind introduction. So, pancreatic cancer is, sorry, I'm just sorry, this thing is not moving. Sorry for the glitch. My screen's okay. It started moving now. So pancreatic cancer is a genetic disease. It's characterized by inherited and acquired mutations. Both broadly, they're classified into three categories: those of oncogenes, tumor suppressor genes, and the genome maintenance genes. The oncogenes would be KRAS, BRAF, AKT2, and MIB. Tumor suppressor genes include CDKN2A or P16 as it's better known, P53 and SMAD4. And genome maintenance genes would include the MSI genes, BRCA, and its partner PAL-B2. Now, pancreatic carcinogenesis is a multi-step phenomena. It's characterized by specific genetic mutations that take place during evolution of a pre-invasive pancreatic neoplasm to invasive pancreatic cancer. Please note that the genetic alterations occur in an ordered sequence rather than a random fashion. A pancreatic ductal adenocarcinoma typically arises in the background of a precancerous lesion, what we call as PANIN or pancreatic intraepithelial neoplasia. This becomes more dysplastic with successive accumulation of genetic aberrations. A quick snapshot here won't go into much details, but on the left is a normal duct, and on the extreme right is the invasive pancreatic ductal carcinoma. And you have these mutations which start in a sequential manner. KRAS, of course, is the most well-known associated gene with pancreatic ductal cancers. KRAS, HER2, and EGFR to begin with. During the course of PANIN, there is inactivation of CDKN2A gene, inactivation because it's a tumor suppressor gene. And later on, P53, SMAD4, and BRCA constitute the important members to drive the pancreatic carcinogenesis. Also remember that there are mucinous pancreatic neoplasms, basically cystic mucinous pancreatic neoplasms, and interductal papillary mucinous neoplasms. These are also forebearers of invasive pancreatic cancer. So KRAS mutations and inactivation of CDKN2A gene, they're observed in almost all. So if it's like as high as 90% of sporadic pancreatic cancers. This combination of P16 and KRAS is uncommon in any other human solid tumor, and therefore is considered a molecular signature for pancreatic cancer. P21 gene activation is an early event in pancreatic cancer. As the tumor progresses from PANIN to invasive, its frequency increases from 9% to up to 85%. CDKN2A itself is inactivated at a later stage as compared to KRAS mutations. P53 is observed in as high as about half to two-thirds of pancreatic cancers, and itself is a late event in pancreatic carcinogenesis. SMAD4, which plays a critical signaling through the transforming growth factor beta pathway, is inactivated in about 55% of pancreatic cancers. BRCA1 and BRCA2 are somatically mutated in most advanced pan lesions. Germline mutation in either gene of BRCA represents the earliest risk factor in many familial pancreatic cancer cases. And if you have that germline gene, then it puts you at a tenfold risk of increasing chance of developing a pancreatic cancer. Coming to KRAS, so that's the hallmark for pancreatic cancer. As high as 90% of pancreatic ductal carcinomas harbor the G12 mutation. That's in exon 2. Codon 12, exon 2. RAS plays important roles in signaling, which regulates cell growth, cell differentiation, and also inhibits apoptosis. So essentially, it's a net growth gene. It switches between the inactive GDP bound state to its active GTP bound state. Point mutations at G12, G13, and Q61, which is in the exon 3, inhibit the intrinsic GTPase activity of RAS, thus sustaining the GTP bound active state of RAS expression. So it's inactive when it's bound to GDP. It becomes active when it is in the GTP state. GTPase activity, when it is inhibited, it stays in the active GTP bound state. Now, constitutively activated KRAS subsequently upregulates EGFR. So they both act to increase the activity of the RAF, MEK, ERK activity, leading to intraepithelial neoplasia. Also remember, this KRAS also activates the pancreatic stromal cells and immune cells, thus further contributing to the neoplastic progression of the cancer. P53 is a tumor suppressor gene. In about 55 to 75% of pancreatic ductal cases, there is a alteration in P53 gene, which includes missense mutations as well as deletions. Biologically, P53 functions to inhibit the cell proliferation by inducing what is known as a protein 21 expression, promotes apoptosis of tumor cells by stimulating BAX, and generally maintains genetic stability, and therefore it's also called the guardian of the genome. Now, MDM2 antagonizes P53 directly, or what is called through ubiquitin-dependent degradation, and therefore inhibition of MDM2 therapeutically may increase the activity of P53 and restrain P53 mutant cancers. CDKN2A is a cyclin-dependent kinase inhibitor 2A, also called as P16. About 60% of patients with pancreatic ductal cancers harbor mutations in CDKN2A. Germline mutations in the same gene are also associated with a high risk of developing cancer. Now, this is a multifunctional gene. It produces P16, arrests the cell cycle during the GAP1 synthesis checkpoint stage, and that it does through inhibition of cyclin-dependent kinases, that's CDK4/6. CDK4 and CDK6 are potential therapeutic targets of tumors which show mutations in CDKN2A. CDK4/6 inhibitors, ribociclib and palbociclib, block the DNA repair machinery, therefore also increasing the sensitivity of the ductal cancer to PARP inhibitors. Coming to SMAD4, it's also called as DPC4, which stands for deleted in pancreatic cancer 4. About half of the patients of pancreatic ductal cancers harbor SMAD4 mutations. It's a tumor suppressor gene. It mediates pleiotropic multiple pathways downstream of TGF beta, prevents tumor promoting activity of pro-inflammatory cytokines, and induces cell cycle arrest and apoptosis. That's its natural mechanism. When you have a mutation in SMAD4, it prevents a normal transduction of TGF beta. Therefore, it switches from a tumor suppressor to a tumor promoter function. Now, if you do immunohistochemistry for SMAD4 and there is a loss of SMAD4, that is an independent prognostic factor associated with tumor progression, epithelial mesenchymal transition, and therapy failure. Now, TGF beta signaling pathway also mediates the tumor stroma interaction. SMAD4 loss of function is also associated with mucinous cystic neoplasms. Now, overall, if you have a SMAD4 gene alteration, that's bad news, and it's reduced overall survival, which has been correlated with the gene alteration in SMAD4. Coming to BRCA, frequency of BRCA mutations is about 6 to 7% in pancreatic ductal adenocarcinoma cases. What you need is biallelic inactivation of the BRCA2 gene at the late stage of pancreatic tumorigenesis. Now, PARP1 is involved in the base excision repair. It basically repairs the single strand breaks versus BRCA, which repairs the double strand breaks. Now, cells with DNA damage will eventually die, or they will acquire oncogenic potential if they do not die. Now, PARP inhibition leads to failure to repair these DNA lesions. So subsequently, when there is a double strand break, when the DNA replication fork is encountered, which means that when you have the DNA which actually at the replication fork, it kind of bifurcates. So you will have a double strand breaks. Now, BRCA deficient cell repair these double strand breaks through error-prone pathways because they have deficient BRCA. This contributes to genomic instability resulting in cell death or oncogenesis. Therefore, a subset of patients with BRCA mutated ductal cancers will benefit from PARP inhibitors, as application of PARP inhibitors to BRCA deficient cells will cause significant lethal effects. So that's synthetic lethality. Now, germline BRCA mutations are generally heterozygous in nature, which means that one of the alleles is still functional. Now, there's an important caveat when you have to see a BRCA mutation test. It's that per se, it doesn't imply that it's sensitive to PARP inhibitors unless the mutations are biallelic, which means there's the other allele. Remember, it's heterozygous. So if you have a somatic alteration in the other allele, then it becomes deleterious. So therefore also becomes unstable genome phenotype, and this confers sensitivity to DNA imaging therapeutic agents. Now, pancreatic ductal cancer divided into 4 molecular subtypes according to the structural rearrangements, and the unstable genome subtype is most sensitive to DNA damaging agents. These include platinum compounds, PARP inhibitors themselves, and even radiation therapy. Now, all of us know about deficient MMR, that's MSI unstable. So about 1% of human pancreatic ductal cancers carry somatic inactivation of the mismatch repair genes. And these are characterized by a hypermutated genome. So as compared to about 1 mutation per megabase in most sporadic ductal cancers, these subset of tumors have about 10 somatic mutations. Now, these tumors carry high neoantigen load and show significantly improved responses to PD-1 blockade. Now, there are mutations besides the KRAS. In KRAS, wild-type ductal cancers include ALK amplifications, just about 0.1. BRAF mutations about 2%, NREG1 fusions 0.5%, and NTREG gene fusions in about 0.3%. Now, these tumors might well respond to targeted inhibition of their altered pathways. HER2 amplification has also been reported in about 2% of pancreatic ductal cases. And if you do get HER2 amplification, it correlates with lung and brain metastasis. Now, a quick word on the tumor stroma interface. The tumor microenvironment is not only the tumor cells, but also the fibroblasts, immune cells, endothelial cells. All of us know that the pancreatic ductal cancers have a voluminous, dense fibrous stroma. Now, this also limits efficacy of standard cytotoxic therapy, targeted agents, or even immunotherapy. The stroma-derived cytokine CXCL12 is taken up by the tumor cells and promotes tumor progression, mets, and chemo resistance. Pancreatic cancer cells themselves secrete sonic hedgehog protein that's called SHH, which induces desmoplasia in a paracrine fashion and supports pancreatic tumorigenesis. Now, this is a landscape for pancreatic tumors, and I'll just leave it at this. And lastly, wind up by having a quick word on GP NENs. I know I'm supposed to talk on exocrine pancreatic tumors, but it's interesting to know that NECs they have distinct p53 and mutations and RB1 inactivation, which sets them apart from the well-differentiated NETs, which basically have MEN1, DAX, and ATRX mutations. Poorly differentiated NECs have mutations in KRAS, CDK, and 2A, and SMAD4. Remember, these are the genes which are also implicated in pancreatic ductal tumor carcinogenesis. So probably behaves as worse as them because of these mutations. They typically have RB1 mutations. When you do immunostaining, you can check for RB1 loss, and immunohistochemistry for P53 will show P53 mutants. So they are genomically unstable subset, poorly differentiated NEC, and therefore also respond basically to the chemotherapy that one would give for pancreatic ductal cancer. So I think that's it for my talk. I'm happy to take any questions.
So if there is any question, we can have one or two quick questions. We still have the 1 minute. Thanks, Dr. Jay Mehta, for timely finishing it. So can I ask you that how much you are prepared as on today to do the molecular study which are clinically relevant in metastatic pancreatic cancer, more than the BRCA1 or let's say MSI?
Yeah, I think that NGS panels that we have adequately cover most of the mutated genes in pancreatic tumors, ductal adenocarcinomas. So that's the answer is yes. I mean, not only our lab, but most labs in the country, I think, who do NGS are well equipped to handle this complex problem.
Can I ask a question, Dr. Naresh?
Yes, please, Ankur.
Yeah, sir.
Yeah,
Dr. Jay, hi, sir. So as we seen many tumors that the tumor evolves, the problem with pancreatic is the desmoplastic reaction or the stroma. So does a new biopsy or a new metastatic biopsy helps as in other kind of breast, colon, or even lung cancer when there's an evolution? So is this evolution known, or we should do a NGS on a parent biopsy or the preliminary biopsy which was done upfront?
So as with most tumors, you tend to acquire, passenger mutations as you grow. If you have a very early stage pancreatic cancer, as I mentioned in my first slide, it's a sequential step, and all these mutations happen in a sequential fashion. It's not random. So if it's kind of an early disease, yes, it would make sense to go for the latest biopsy. Tumor stroma, yes, that makes an issue. When you do NGS, you also need a limited, you need a very specific amount of tumor tissue also in it. You can't have less than 5 to 10% tumor, because that's going to give you false negatives. So yes, but I would say preferably one should take the metastatic side, because that would have evolved, the cancer evolves, and you have the latest, all the mutations. If you get some actionable mutation in that, then that's very helpful for you to treat.
And many times, Dr. Jay, the tumor is locally advanced or unresectable, and it remains unresectable. We give chemotherapy, and at times we give radiation to consolidate, and we do not have a biopsy many times in pancreatic cancer. It remains, unless and until it is metastatic, it remains locally advanced many times. So is there any evolving role of a liquid biopsy in such kind of patient? Because we can do only germline BRCA testing in them. So there's no somatic tissue apart from a cell block or a FNAC, which generally leads atypical cells or malignant cells. We do not have tissue beyond it. So how can we crack down this nut?
Yeah, so liquid biopsy might provide the answer. I mean, you have more and more of this Guardant, things like Guardant 360 liquid biopsies, which kind of give you answers. They're not FDA approved right now, but I think the science is evolving, and I don't see any reason why liquid biopsy shouldn't be giving any answers going forward. So yes, I mean, this kind of a cancer, yeah, you would have to rely on the liquid biopsy.
Thank you.
Because it's difficult, as you said, to obtain somatic tissue for testing.
Thank
But
you.
Jay, can I say that 50% of patients with, locally advanced cancer do not have any circulating tumor DNA?
So therefore, we need to wait for the technology to evolve, Dr. Bhavna, where which the sensitivity, the clinic analytic sensitivity of the test is that low that it picks up. Because what would you do if you don't have any starting material and you still need to do genomic testing? That's about the only test left then to help you out.
Yeah, that's true.
So I
So as
think
of now, this KRAS testings are not, approved for treatment or any kind of approval basis on them.
so. I think we should close this topic here in the interest of the time and interest of the everyone. So let me invite our next speaker, Dr. Sailesh V. Srikhande, young, dynamic, pleasant surgical oncologist from the Tata Memorial Hospital. He is deputy director. He is the head of the pancreatobiliary hepatic surgery and the GI surgery at the TMH Mumbai. Dr. Sailesh V. Srikhande will be talking about the what's new and what's standard in the pancreatic cancer surgery. Dr. Sailesh V. Srikhande, please.
Yeah, thank you, Dr. Somani, and thank you for the invitation. Real pleasure to participate, and I'll try to share with you my screen. Just give me a minute. Are you able to see my screen?
Yeah, no.
Not
We
yet?
are able to see your email, something like the mail between you and the group.
If you open your presentation, yeah.
I clicked screen share. Now, are you able to see it?
Yeah. You need to go to the full screen.
Is that good now?
I think still it is not. Yeah, yes.
Are you able to see now?
Yeah, yes, please go ahead.
Right. So are we making progress in surgery of the pancreas? We are fortunate that we have less of pancreatic cancer as compared to the Northern American as well as the Australian and the European continents. Having said that, we clearly have problems of reporting, documentation, and awareness. But with more diagnostics and sheer numbers of 130 crores, what we have seen at the Tata Memorial has just been an increase in the number of periampullary tumors as well as pancreatic cancers. Let's talk about the surgery bit of it. I think the red box tells you where the surgeons have come up in a big way. This red box was smaller a decade ago, where we would treat only resectable disease. And borderline resectable and locally advanced would all be considered as advanced cancer. And even now in non-specialist units, borderline resectable is considered as unresectable. And I'll share with you my experience about what has been the progress in surgery. So if you have an artery which is involved less than 180 degrees or a vein which is more than 180 degrees, this is surgically removable. So what we have done now is that a number of BRPCs would become resectable, and a small percentage of unresectable would now become borderline resectable or resectable. We started this journey about a decade ago, and you require good radiology. And I want every person interested in management of the pancreas that when we speak of vascular involvement, you need to look at three things. One is the length of contact, one is the circumferential contact, and one is the venous deformity. Three factors which will dictate what we can do and what we can't do. You've got phenomenal radiology now, so I can get the length of contact, circumferential contact, abnormal vasculature, and plan my surgery very well prior to even taking the patient anywhere close to the operation theater. And this would have an accuracy of more than 95%. What I would see on a CT, a triphasic high quality CT, I would see this on the operation table as well. Now we need to look beyond the conventional pancreatic resections. That's my brief for the lecture today. And this is data from my GI and pancreas pathologist that 57% of our pancreatic head or uncinate process tumors turned out to be positive, in other words, R1 resections, which were predominantly the posterior margin and the margin close to the superior mesenteric artery. And that means that you have to go not the conventional Whipple operation, but you have to go to the superior mesenteric artery, safeguard the arteries, and you can remove everything else with much better results, as I will show you. So this is something with which I've been closely associated with, a technical concept in pancreas cancer surgery, approaching the SMA first, not touching the tumor, and being able to assess it quickly, and in many cases previously considered inoperable, we would be able to take them out. In addition to that, there was good work from Japan at the end of 2015, where I just want you to look at the three black lines, those who are surgically inclined to understand. LV1 is a conventional resection. LV2 would mean a vein resection, while LV3 would mean nearly locally advanced. You go sub-adventitial, the yellow is the adventitia. You go beneath the adventitia, safeguard the artery, but you remove the entire mesopancreas as well as the nerve and lymphatic tissue to make sure that locally you completely take care of what remains clearly a systemic disease. So this is a picture which more than 10 years ago was very often inoperable. But you see the white line, you see the SMA is safe, and what we are doing is a tumor with a vein resection where tumor is out and the vein is joined back, and what you get is a primary anastomosis which is taking care of the anastomosis and taking care of the cancer in terms of a resection. So this is one situation. So now what do surgeons do? The yellow area is the tumor, and I can get a safe margin and I'm a happy surgeon. The bigger tumors involving larger parts of the vein, I'll still get an SMA first and I will be fine. And the tumors get even more bigger and I can technically do it, but I'm somewhere in two minds. Am I really helping the patient? So that's when the crosstalk between surgeons, medical oncologists, and radiation oncologists tends to come in. And why is this important? Because we have got data. We've got a randomized controlled trial. It has problems. It has powers problems. It has other problems. But nevertheless, there are advantages of giving neoadjuvant treatment. In this trial, it was neoadjuvant chemoradiation with gemcitabine versus upfront surgery in borderline resectable pancreas cancer. And you can see that there is a difference in the 2-year survivals. You will see it was intention to treat analysis, and you will see the difference in the Kaplan-Meiers as well. Another study from the Johns Hopkins group, it is retrospective but very relevant again. Patients with PAT-CR versus non-PAT-CR, and again, a huge difference as far as the Kaplan-Meiers are concerned, with excellent long-term survival, where people have got neoadjuvant chemoradiation in patients with borderline resectable disease. And continuing further, we have got meta-analysis, two of them which are well known. This was the one in 2018. The first one was 2016. It does improve the R rates in terms of resection rate, and R0 resection rate is clearly much better with neoadjuvant. But the resection rates come down as compared to upfront surgery. Though it looks good here for someone who wants to focus on neoadjuvant treatment, the jury is very much out because we don't know how many were potentially denied a resection when upfront surgery was also possible in the group of borderline resectable pancreas cancer. Giving good chemotherapy and radiotherapy, we are now able to do multivisceral and extended pancreatectomies as well. And in this, we have shown that you can do vascular resections, you can do vein resections, you can do arterial resections. And I would have about 4 out of 10 people who are alive at the end of 3 years after having received radical surgery. For example, in this picture, I resected the hepatic artery, divided the splenic artery. Tumor was mainly involving the hepatic artery, got the splenic artery and joined it back to the right and left hepatic artery, safeguarded the liver. Rest was clean. Patients have continued to do well. Now we want to take it further. You see a tumor which to all of us is inoperable. This is celiac axis involvement, hepatic artery involved, splenic artery involved. Patient has now sent us a happy Diwali and a happy New Year message 1 year after surgery. Chemotherapy given, excellent response, young lady in her mid or late 40s, good biochemical response in terms of CA19-9, symptomatology, good ECOG status. We have resected the celiac axis. We have bared the superior mesenteric artery. That's the portal vein. We have divided the splenic vein, and we have done a subtotal pancreatectomy. Only the head and the uncinate remains. Blood supply to the liver was maintained via the gastroduodenal. If it would not be, we would take the hepatic artery junction here and join it to the aorta with the help of a graft. So operations like these, completely inoperable, is not so. In selected patients, we can do that. I have a patient again who has done well for more than 2.5 years after receiving FOLFIRINOX, radiotherapy. I tried my best to tell him, don't get operated, because even I wasn't sure. But when you see that there is no tumor and they recover well, and you are able to do a vein resection, you are able to resect and remove tumors from the celiac axis. That's the hepatic artery where the tumor was encased. This is known as divestment technique. You don't have to resect an artery, but pancreatic tumors which have responded well to chemo and or chemoradiation can be shelled out, and then it's easy to go ahead. So I think the disease is old. It was always there, and nothing about it has changed much. We heard the lecture from Jay, and we know a little bit more about it. And we now understand it better, so we are able to treat it better. Same thing for pancreatic body and tail tumors. We are able to give them a fairly good 3-year overall survival, as well as disease-free survival. For tumors which are traditionally detected late, more as compared to the head, we detect body and tail tumors later, but with radical antegrade modular pancreatosplenectomy, we are able to get good results. This is something which I want to share, and people must know about this. This is a data of about 50 patients, and these patients were operated for a planned Whipple's operation elsewhere. And the surgeon has opened, done a bypass, or said that there is vascular involvement and can't be done. We looked at the CT scans of these very patients when they were offered surgery elsewhere, and we felt that maybe there is no vascular involvement as such. Some of them got neoadjuvant because we respected the intraoperative findings of the surgeons. And some of them we totally disagreed and did not give any neoadjuvant and went straight away for a trial attempt to removing the tumor. And the commonest cause for denying resection at initial surgery was suspected or perceived vascular involvement when it was not there. So you get the same outcomes, you get the same surgery, and it's just a matter of specialization. So today, where does surgery come? We have these 4 categories, and clearly surgery will remain the cornerstone in resectable disease when it comes to resectable, borderline resectable, and in some cases of locally advanced. And this number is approaching close to 30% in some series, thanks to arterial divestment or arterial resection. This is not good data, but it's from a world famous unit where I was working long time back. And the data is depressing, but this is locally advanced pancreatic cancer. They will get 12 patients who are alive at the end of 5 years, but they do have a median survival of 21 months. And even complex surgery in the last 7 years, even for arterial resection, is less than 5%. So you can do supramajor operations, which were unheard of before. And this is just published last month in the Annals of Surgery. Apart from surgery, we will also make progress in the multidisciplinary care. And this is our own data from enhanced recovery after surgery. You see that patients, if they have more than 80% compliance to a dedicated ARAS protocol, which is run by my chief GI lead anesthesiologist, you will have much better outcomes, even in an Indian circumstances, if you implement critical components and elements of the ERAS program. This is the data at Tata Memorial every year, and we've done more than 1,000 in the last few years. So we have clearly grown as a dedicated pancreas unit. And even in the COVID year, we have had some mortalities, more than the previous years, but our numbers would still be very good because we have continued offering cancer care. And we've published our data of 1,200 Whipple resections, and you will get about 78% patients who are alive at the end of 2 or more years, and close to 30%. And with periampullary tumors, we would get close to 40 to 50% patients for all stages put together who would be alive at the end of 5 years after complex pancreatic surgery. We have looked at data across the country, and we divided and looked at this data. The last time I published on volumes outcomes in India was in 2008 in the journal Pancreas. And after 11 years, I decided to look at data again. The various centers in the country which have published their work over a period of time. So the publications has increased. I think this is Pancreas Cancer Awareness Day and month. So it's good to know that more people are coming out with their data and more people are presenting their data. But of course, it's still a long way to go. But what you can see from this is that if you do more than 25 cases, you are likely to be doing much better as a team in terms of your outcomes. This is not exactly surgery, but surgeons are going to be involved in this. And this is just very recently published, that what do we mean by precision oncology in surgery? And you might be already aware of these biomarkers. And you can see that if S100, A2, and A4 are both negative, people live much longer. While if both are positive, people live much less. So I think we are moving in the directions of trying to get better biomarkers, which might direct patients as to who would benefit with surgery at what time. So it's about sequencing of surgery. We ourselves do a fair bit of research in pancreas cancer. Difficult to put surgery away or chemotherapy away or radiotherapy away. They would all remain an integral part as we try to improve outcomes in pancreas cancer. You are aware of this, that now we have 4 different types, or rather subtypes, of pancreas cancer. And you have this example. Again, I want you to know that bad cancers, but with surgery, you get good response first, then there is recurrence, and then you are able to identify the type and then decide whether what kind of platinum therapy you could give and keep patients alive for more than 2 years, 2.5 years, 3 years, which was something which was unheard of 10 years ago. So we made progress as a team. Of course, what I discussed as far as upper end surgery is concerned, it's important to be aware that I will not look only at radiology and anatomy and my surgical skills. I will look at the patient's biologic response as well as the patient's condition. That's going to influence our decision making. So this is my last slide. We as surgeons and as pancreatic specialists, we will treat an increasing number of pancreatic cancers in the coming years. We'll clearly detect also more cases, maybe incidentally, but see them in earlier stages than ever before, where the treatment would be more optimistic and less nihilistic. Radical high quality surgery, all words are important in this, will remain the cornerstone of curative treatment, but we would only be working very closely with all of you in a multidisciplinary clinic. Chemotherapy, I think FOLFIRINOX has been an improvement over gemcitabine, but I still clearly need more convincing chemotherapy in a bad cancer, which has so many genetic mutations and variations. And it will play a relevant role, both neoadjuvant as well as adjuvant, especially in borderline resectable and locally advanced disease. Role of radiotherapy is not done yet. I know it went down a little bit, but I would believe that it's going to come up again. And we already are running a trial at the Tata Memorial called the NEVAS trial with Dr. Reena Engineer. And we will try to see what comes out of it with SBRT as well. And then there will be precision oncology making small but steady progress, which will improve the way we want to give personalized care in pancreatic cancer. And all the work that I presented here is our team at the Tata Memorial, the gastrointestinal disease management group, all of them focused only on GI cancers from all the specialties that you can think of. And the left upper picture is the group of surgeons that I lead, both in HPB and gastric as well as colorectal surgery. Thank you very much for your kind attention.
Thank you, Dr. Srikhande. It's a wonderful, I will say that it's a sort of oration. And you are the captain who wins the match as well as the championship also. No doubt in that. Can I ask you one straight question? What message you would like to give to all the medical oncologists here, that how we can select in a combined way the patient for the neoadjuvant systemic treatment?
So I think it's very simple. If you are sitting with your radiologist and your dedicated pancreas surgeon, you will be able to clearly decide the sequence of treatment you want to offer. One. That's why I showed that old slide of radiology, that we started looking at tumors which were previously considered inoperable right here in Tata in 2008. And we published that in 2011. You just need the radiology input of how much is the vasculature involved in terms of anything more than 180 degrees. I think I would err towards giving neoadjuvant treatment, but also look at the patient's ECOG status, look at the tumor marker CA19-9 despite its low sensitivity and specificity. If it is high, if the performance status is not good, even if it's resectable, perhaps surgery is an overkill. But I would say the very first couple of visits, it should not be that only the surgeon sees the patient or only the medical oncologist sees the patient. Everyone should see the patient right at the beginning, and then you will be able to establish and direct them for appropriate lines of treatment.
Dr. Salas, few years back, there used to be many editorials where the philosophy was that you give the chemotherapy, which has the response rate something like 30–40% with the FOLFIRINOX. And the patient has the progression of the disease or they develop the metastasis within 2 months, let's say with the 2 or 3 cycles. So it is sort of the good thing has been done with the patient, avoiding the Whipple's kind of the surgery. So as on today, do you believe this concept?
I believe this concept, but only in a subgroup. We don't have too much of an analysis. So this concept is true. The minute you have poor prognostic factors looking at you, a large pancreatic tumor, in the absence of obstructive jaundice, a high CA19-9, yes, you can do a Whipple's, but you might be in trouble, especially if it's borderline resectable. Now, the world wants to ask the next question, that in resectable disease, high CA19-9 localized disease, no vein resection required, would I go ahead with neoadjuvant? The answer is a no from me, based on the evidence that's available, even if it means that perhaps 10 or 15% patients in hindsight might receive an unnecessary Whipple resection. I don't deny that some of them will fail early. But as I said, you will get about 78% patients who are alive at the end of 2 years after curative surgery. So I think in resectable disease upfront, in borderline resectable disease, and we are looking at our data of 190 cases, hopefully it will get published soon. The jury is very much out about upfront versus neoadjuvant, but more the vascular involvement, better to give neoadjuvant. Even if some of them progress on neoadjuvant, it's fine. They will not get surgery. That's okay.
Thank you. Any other
Shailesh,
questions?
I have a question, Dr. Somani, to Dr. Shailesh.
Yes,
Dr. Shailesh, in your practice in Tata Memorial, what are those patients who get adjuvant radiation post-Whipple surgery?
Almost never, because our radiation oncologists believe that if at all we have to give radiation in borderline resectable disease, it is to be given pre-operatively. The other belief is that supposing I get a margin which is positive and all the lymph nodes are negative, and my R1 margin only at the vessels, though on table it was R0 and nice and clean and soft planes, my pathologist by the Leeds protocol or the Royal College of Surgeons of Pathologists protocol tell me that no, but even then your vein or your artery margin is coming as R1 disease or within 1 millimeter of your transection plane, and all lymph nodes are negative. In that case, I have sometimes individualized and given them radiotherapy because I would be more worried about local recurrence. But the minute you have disease which is involving perineural invasion, lymphovascular emboli, or lymph node positive, I think the key is adjuvant chemotherapy. The key is not radiotherapy, because the disease is already, it's less of a local problem, more of a systemic problem.
Yeah.
So if no more questions, can we move to the next session? Thank you, Dr. Yeah, thank you, Dr. Kailash Khande once again. And I invite the next speaker, Dr. Ankur Bahal, Senior Medical Oncologist from the Max Super Specialty Hospital, Delhi. He will be talking about what's new in the management of the pancreatic cancer, especially in the advanced pancreatic cancer. Dr. Ankur Bahal, please.
Thank you, Dr. Somani, and giving me the opportunity, and a wonderful session by Dr. Shailesh. Wonderful data he presented for Tata Memorial. So I'll be speaking on the newer treatment option in pancreatic. As such, nothing big has happened in pancreatic, and we don't believe that much will happen because of the basic biology of the stroma, but many attempts have been undertaken, and I'll share a few attempts of the vaccines and the new and the playing with the FOLFIRINOX and all. So let's proceed. So these are the key milestones which has happened in pancreatic cancer over last 4 or 5 decades. We started with 5-FU, then came a bit of mitomycin. Then it was 1996-97 when gemcitabine made a difference and actually gave a survival advantage. Then came a gem-erlotinib combination, which gave a few weeks advantage. And the basic thing which came was FOLFIRINOX data, which was combined with gemcitabine and then we were talking about survival in metastatic pancreatic cancer in more than 10 months or 11 months or so on. And then came a combination of gemcitabine and nab-paclitaxel, which says that those patients who are unfit for FOLFIRINOX, it has own its limited complications. So those patients can be given gem nab-paclitaxel, and it was better than gemcitabine alone. So here onwards, the journey started, and now we are in the era of immunotherapy, area of vaccines. So let's see how our newer treatment options comes up in pancreatic cancer. So the rationale of platinum-based therapies in advanced pancreatic cancer came from the BRCA1, which I believe Dr. Bhavna Siroy will give justice in the next presentation. So platinum-based therapies, we know, induces DNA damage when there's a homologous recombinant deficient cells, and it results in increased instability and more pressure on the DNA repair mechanism. So it is important to get BRCA1 germline testing upfront. We know that the role of olaparib, niraparib is in the maintenance therapy, but the simple test done on blood or saliva will actually give us a predictive response to platinum. If the BRCA1 is mutated or we have a homologous repair deficient cells, then platinum will do wonders, and we have to choose either FOLFIRINOX, which have oxaliplatin as a platinum, or we should use gemcitabine cisplatin, which is also a category 1 recommendation for pancreatic cancer. So there's an established role of platinum-based chemotherapy in pancreatic cancer. We have discussed this. So FOLFIRINOX is generally the first-line treatment of choice in metastatic pancreatic cancer. It has 5-FU, folinic acid, irinotecan, and oxaliplatin. So although these 4 drugs has serious side effects like febrile neutropenia, neuropathy, and vomiting, but only this combination in patients who have good performance status has given both PFS and OS advantage. However, we are using various modified regimens of FOLFIRINOX, or we can remove irinotecan or use only FOLFOX if patient cannot tolerate this. And gemcitabine cisplatin may be considered as an alternative platinum regime in such patients. So NCCN recommends both FOLFIRINOX or gemcitabine plus cisplatin as a preferred first line for patients with good performance status. And if we have a germline BRCA mutation, then obviously we should use platinum upfront as compared to gemcitabine or NAP albumin-bound paclitaxels. And if the patient is having a poor performance status, then best supportive care or a single-line agent, gemcitabine or capecitabine or just 5-FU infusion can be given. But however, we do not have such hopes in poor performance status patient with a metastatic disease. So yes, it was PRODIGE 4 or ACCORD 11, which showed the superiority of FOLFIRINOX over gemcitabine, 11.1 versus 6.8 months, hazard ratio 0.57, and very significant Kaplan-Meier separating the red one separating from the blue one. The red is FOLFIRINOX. However, we know the complication of FOLFIRINOX involves a PICC line, involves a chemoport insertion, and an infusional in-bed or a pump requirement. So PRODIGE 35 was an attempt to decrease the toxicity and to manage such patients. So it was a randomized study involving 3 arms, equally patient, 89 or 90 patients in each arm. The first arm was FOLFIRINOX, and the other arm was FOLFIRINOX 8 cycles, and then give them some rest from chemotherapy, but give them 5-FU leucovorin infusion, and then continue FOLFIRINOX. So 90 such patients. And the third arm was alternating gemcitabine with FOLFIRINOX and gemcitabine. So we clear-cut saw that so the red line and the purple line are the FOLFIRINOX alone or FOLFIRINOX, leucovorin, and FOLFIRINOX. They both were equal. So if patient has, so this is very practical study. So if the patient has toxicities from FOLFIRINOX, if we give them a rest and give them only 5-FU leucovorin and again continue with FOLFIRINOX, it was non-inferior to FOLFIRINOX alone, 10.1 versus 11.2. However, both the FOLFIRINOX and the FOLFIRINOX leucovorin and then FOLFIRINOX was superior to gem FOLFIRINOX alternation. So this is a modification of PRODIGE 4, came by the name of PRODIGE 35. So we need to see the larger studies, and it is actually a practical when the patient is exhausted by FOLFIRINOX, so much of fatigue, nausea, vomiting, and at times febrile neutropenia and complications. I'm not able to. Yeah. So yes. So NAP paclitaxel plus gemcitabine is also recommended for metastatic pancreatic cancer who cannot tolerate FOLFIRINOX, and this came from the study which was gemcitabine and NAP paclitaxel compared with gemcitabine. It gave both OS and PFS advantage. So this is another combination of drug which was PAXG. PAXG stands for cisplatin, NAP paclitaxel, capecitabine, and gemcitabine. So it was compared to the standard NAP paclitaxel and gemcitabine, and it clear-cut gives both PFS as well as OS advantage, hazard ratio 0.56 and hazard ratio 0.60 in favor of OS, PFS and OS respectively, 14.4 versus 10.7 months. So this is also a combination, seems difficult and toxic, but yes, it is one of the approach when we can use cisplatin nab-paclitaxel, capecitabine, and gemcitabine. So platinums are being used along with gemcitabine, along with taxanes. So this also is a phase 2 randomized study called as PAC-19 study. So this is a real world evidence which clearly says that FOLFIRINOX is better than Abraxane in all the 3 studies. It was the Kaplan-Meier shows in favor of FOLFIRINOX if the patient is fit enough to take it. Also, a greater proportion of patients receive second-line therapy after first FOLFIRINOX. So FOLFIRINOX, this look sensible that FOLFIRINOX is given only when to the fit patients, and when they progress, they receive the second line, which is gemcitabine and nab-paclitaxel, and the graphs showing that the overall survival advantage and median time to duration of next chemotherapy is in the favor of FOLFIRINOX. But if the patient has used more than 1 line of therapy, whether it is FOLFIRINOX or nab-paclitaxel and gemcitabine, or Abraxane upfront and then FOLFIRINOX later, the OS remains same. So if the patient has tolerated 2 lines of therapy, then there is no advantage of using one over another. But yes, FOLFIRINOX patients upfront gives an advantage over nab-paclitaxel and gemcitabine combination. So we have discussed this before, the efficacy of platinum-based therapy, particularly when we have a BRCA mutation or homologous repair deficient patients. So if platinums are given in such patients, the overall survival is better, and the Kaplan-Meier splits wide apart. And in platinum-naive patients, we do not have an advantage in these patients. But if a BRCA mutation or homologous recombinant mutation or PAL-B2 mutation is present, then there's a clear-cut advantage of adding platinum. So BRCA is predictive and BRCA is prognosticative in pancreatic cancer. The various studies says that it has a superior prognosis when BRCA mutation is present. So this we have discussed. So if the patient is not fit for FOLFIRINOX, and the patient is BRCA mutation positive, then we should think of gemcitabine cisplatin or gemcitabine carboplatinum, particularly when BRCA mutation is present. And there have been attempts done with combination of PARP inhibitors with chemotherapy, cisgem and veliparib compared to cisgem alone. So there was no much difference in PFS and OS. The p-value was non-significant. So, but these attempts have been done, and majority of the attempts in pancreatic cancer, particularly in medical oncology, have more of a failed study rather than a positive study. So this was a real-world evidence confirming the sensitivity of platinums in BRCA mutation or PAL-B2 positive. We can see if the mutation is positive, the purple line is clear-cut far beyond the blue lines in the Kaplan-Meier curve. So it was 1997 when we had gemcitabine showing a more clinical benefit than 5-FU. Then came FOLFIRINOX in 2013, then Abraxane, and now we have POLO-1 data, which Dr. Bhavna Saroy will be telling. I'm not going to the POLO trial. So yes, we have done some advantages, but the advantages in chemotherapy regime, the various combination has not given that much result, which we have seen in other cancer. So the first line treatment of metastatic pancreatic cancer depends upon the performance status and the age of the patient. If the patient is fit and young enough, go for FOLFIRINOX and then Abraxane later. If the patient is elder and could not tolerate this platinum and irinotecan combination, then we can go with gemcitabine combination or single agent alone if the performance status does not allow us. So recent failures of drug development, the huge negative randomized studies, attempts have been done with many molecules, antidotes, hypoxia, NOTCH3, anti-hyaluronidase, JAK1/2. So all these are negative studies. The main reason for this negative study was a tumor stroma, the desmoplastic reaction, which is not allowing penetration of these agents into the stroma. So various attempt has been done. There was huge discussion about Abraxane when it came in 2000, and it was discussed in 2012 or 13, that Abraxane inhibits the spark protein which is present in this desmoplastic stroma. Various hedgehog inhibitors, hyaluronidase inhibitors, and various other attempts have been done to crack this hard nut, but with the failed studies. So it has mutations, but few actionable mutation. We have heard Dr. Jay Mehta. The MSI being high is not more than 2% in such patients. I haven't seen an MSI high patient in my pancreatic cancer patients. Low mutational burdens, low circulating tumor DNA cell, heavily relying on BRCA1 and PAL-B2 mutations to know the sensitivity to the platinum and then maintenance olaparib, the POLO trial. So these are
Dr.
the
Dr.
yeah.
Ankur, may I request you to wrap up in the next 1 or 2 minutes, please?
Okay, I'm just doing it. So we have few biomarkers, PDL1, we are just concentrating on MSI high, the PARP inhibitors in BRCA mutation, and the rest has been failure till now. Various agents like ibrutinib, BBI-1602, the POLO trial with Dr. Bhavna, pembrolizumab in MSI high tumors, only 1 to 2%, the Keynote 016 trial. So pembrolizumab is approved in all the solid cancer who has mismatch repair deficiency being high. So as such, immunotherapy is not effective in pancreatic cancer. The tumor mutational burden is low in such patients. Attempts with vaccine, GVX, CRS have been done. The Eclipse trial, the Impress trial, where this again Plutocell vaccine has been combined with chemoradiation. We are waiting those results. So enzyme targeting, particularly the PEG-PH20 with chemotherapy regimen has been attempted, but we are waiting these results. So lot of attempt to convert this cold tumor to a hot tumor so that it becomes immunogenic. We have to see the results in near future. Various ongoing research and more than 55 agents in more than 1,500 studies are ongoing. Majority will yield a negative result, but yes, we have to see what comes in the future. Thank you, and I'm open for any questions or comments.
So, Dr. Ankur, thank you for this elaborative talk and almost covering everything, the standard of care presently. Dr. Ankur, I'm not seeing any question in the chat box. So can we move, if there is no question, to Dr. Ankur from anybody? So as on today, as on this moment, no question. So we move to the next session. And we have the next speaker with us, Dr. Bhavna Sirohi, well-known figure in the field of the medical oncology. She has the vast national and international experience. She is presently the lead medical consultant at the Apollo Cancer Center, Chennai. She will be talking about the relevance of the BRCA testing and the PARP inhibitors in the metastatic pancreatic cancer. Dr. Bhavna Sirohi, please.
Thank you. Thank you. Am I unmuted? Yeah. Thank you, Dr. Naresh. This is fantastic that you've arranged this in the Pancreatic Cancer Awareness Month. I think since I started training more than 2 decades ago, the survival for patients with pancreatic cancer has changed. Median survival for advanced pancreatic cancer has changed from 3 months to 6 months. And now we are going to 12 months and 24 months as well with the newer PARP inhibitors that are coming up. So I think for pancreatic cancer, this is a very exciting time. I'm only going to focus on advanced pancreatic cancer. And what is exciting is the DNA repair pathways. We know that when there is DNA damage, we try to fix it. And there are a couple of pathways which are involved in it. We know the PARP1 pathway. Sadly, there is no marker which is available through which we can detect PARP1. So we have to rely on other side things to find out whether the drugs will work or whether this is targetable. Then we have the second pathway, which is the BRCA homologous repair pathway, which helps us repair the DNA. Within the homologous recombination, I think this is a busy slide. I normally don't show cartoons, but I think within the DNA damage, we are still trying to learn what is important and what is not important. Like for homologous recombination, I think the associated mechanisms are with ATM1, H2AX, and RAD51, and you will hear more about it hopefully in the future. People are developing HRD scores. So I think these are very exciting times with all of these markers being targeted. This is from a breast cancer. I thought it is very important to get into the subject because the HR deficient cells are more susceptible to PARP inhibition. And if you see the normal cells, if there is a single strand break, it is repaired because the homologous recombination is intact. With a PARP inhibitor, again, the double strand break is repaired because the homologous recombination is intact in the presence of PARP inhibitor. But if you have a homologous recombination deficient or a BRCA mutation a patient or a cancer or cells, so they are unable to repair the double-stranded breaks and die through apoptosis. And I think this is the whole rationale for my talk today. About 20%, I would say, patients with pancreatic cancer have the DDR1 mutations. We have two amazing data sets, the Know Your Tumor data set and the CARIS data set. I think all of us who treat pancreatic cancer and have done next generation sequencing have seen one of these mutations in the NGS reports, especially relating to BRIP1, BRCA1, 2, ATM, and PALB2. I recently had a patient with ARID1A mutation as well. So the key thing about DDR defects, I feel, is identifying these tumors in patients in time for a window of opportunity of treatment. I recently had a patient whose, we knew that patient had germline BRCA mutation, but I could never get the patient to olaparib because the patient did not respond very well to FOLFIRINOX, which was really sad. Ensuring that these tumors are still reliant or addicted to this pathway. We are now talking about BRCA reversal, which is a mechanism of PARP inhibitors resistance. So again, identifying these patients is important. Making sure these tumors are matched with the precise treatment options. They can be detected through blood, plasma, or tumor testing. And I think Jay covered this really well. The blood and saliva will look at germline BRCA, while tumor tissue. So I had a patient recently who, I'll talk about it in a second, who had somatic BRCA mutation, but then we had not found it in the blood. But when we went back, we were able to find the germline mutation. So Know Your Tumor is a fantastic example of industry and investigator-initiated study where patients get to know their own tumor genomic profile. And this study showed that about a quarter of patients have highly actionable mutation, and the others have a modifiable options which are available. And we're going to focus on the platinum and PARP inhibitor in this talk. So in this study, they looked at HRDDR mutated pancreatic cancers. They all consented to a registry protocol, had a broad-based molecular profiling done with one of the platforms. And as you can see, both for early pancreatic cancer and advanced pancreatic cancer, giving a platinum had a significant survival advantage, especially for patients with advanced pancreatic cancer. The median survival was 6 months more for those who had received a platinum-based therapy. About 5 to 7% of our patients with pancreatic cancer have the germline BRCA1 and 2 mutations, higher in certain populations, especially if there is a family history of breast, ovarian, or pancreatic cancer, when it goes up to 20% as well. So I think it's important to remember that about 40% of patients who are germline mutation carriers do not actually have a history of breast and ovarian cancer. And I think that is the guiding principle behind recommending BRCA testing or germline mutation testing for all patients with pancreatic cancer. So if you look at the first study by Dr. Lowry published a couple of years ago, 42% patients actually did not meet the testing guidelines. And in various studies, you can see that the incidence of germline mutations ranges from 5% to 20%. Regarding BRCA NGS, I think I wanted to make this point because when I came back to India, I was doing BRCA NGS, sending it to my risk is very expensive, costs lakhs and lakhs. So I was doing NGS and the patient was negative, but when we tested the tumor, it was positive. But then I realized that even though the patient has a negative BRCA by NGS, that I must look at the small print and send it for MLPA. So I think the disadvantage with NGS is there's reduced sensitivity for large insertions or deletions. So it's very important that if a patient, especially if they have a positive family history, and they've come back as negative for BRCA testing on NGS, that you must request MLPA testing as well. BRCA-ness is something which we talk about a lot in triple negative breast cancer, and in pancreatic cancer as well, we are talking about it. It just means that These are signatures of BRCA-NES correlate with the response to platinum and PARP-based therapy, and includes not just BRCA, but a huge panel of genes which should be part of the germline mutation testing. Also, it is interesting because people are looking into whether tumor mutational burden may be a candidate biomarker of BRCA-NES, though I think there's still more work that needs to be done in this. So germline testing is recommended for all patients, and I would urge my surgical colleagues and other colleagues to do it in every patient who has early pancreatic cancer as well, because it has implication for their family in maybe getting screened a decade earlier, and also has implications for their treatment when they recur. So ASCO also recommends testing for all, but also recommends the genes that should be included in the multi-gene panel are these genes, and we must make sure that we do not just ask for BRCA1 and 2. We ask for PALB2 as well, because we know that, I'll just talk about it, that the drugs are available for PALB2 mutation as well. Pancreatic PARP inhibition increases pancreatic cancer sensitivity to chemotherapy, as is seen in animal data, but also this fantastic study by Dr. Eileen O'Reilly from Sloan Kettering shows that patients who had a germline BRCA mutation had a median overall survival reaching almost 2 years if they received a platinum and a PARP inhibitor. And I also never forget my first patient who had a pathological complete response with neoadjuvant chemotherapy had a germline BRCA2 mutation, and we switched to gemcitabine cisplatin. So I think cisplatin, gemcitabine plus PARP inhibition, fantastic data showing excellent survival results. This is just a patient where extensive liver mets patient received cisplatin-based treatment, and you can see the mets have completely disappeared. So these are the 4 PARP inhibitors which are available, and there have been trials: olaparib, beliparib, talazoparib, and rucaparib. But I was just Googling and looking at the number of PARP inhibitors which are available. There are 26 registered PARP inhibitors. But I think the only drug which has moved forward in a very positive way has been olaparib, which is licensed in ovarian cancer. So you can see that the response rates as a single agent range from about 15 to 20%. With rucaparib, there was one patient who had a complete response as well. I think POLO study is pivotal for patients with pancreatic cancer who had a germline BRCA mutation and had been treated with prior platinum-based treatment for a minimum of 16 weeks. So, if you're trying to apply this criteria to clinical practice, that's why this patient of mine could not get onto olaparib, because with extensive liver mets, he progressed on FOLFIRINOX. So, and less than 24 weeks of treatment with platinum was one of the criteria for entry into the trial. More than 3,000 patients were screened, and only 247 had the germline BRCA mutation, 7%. Patients were randomized 3:2 to olaparib versus placebo. Progression-free survival was the primary endpoint. And as you can see, the primary endpoint was met in this study. The patients who received olaparib had a median progression-free survival of 7.4 months versus 3.8 months, which was significantly higher than patients who were on placebo as maintenance treatment. They had responded. One must remember that this is not given at the time of progression. This is given at the time the patients were responding. And the median duration of response was 25 months in the olaparib arm, which I think is very, very important and significant for our patients of quality of life, compared to 4 months versus placebo. But again, the criticism I have for this trial is that this does not reflect real world practice. Because what we do in advanced patients with pancreatic cancer is I would not give placebo. If they're on FOLFIRINOX, you carry on some form of maintenance treatment, some form of maintenance strategy, which actually does increase the progression-free survival as well. Point to note is there was no overall survival difference seen in this study, and 35% of patients actually discontinued olaparib because of toxicity. The second study, again, a multi-center study done in US and some centers in Israel as well, a phase 2 randomized study in stage 3-4 patients with pancreatic cancer, gemcitabine, cisplatin plus or minus veliparib. And as you can see that the primary endpoint was actually response rate, and the response rate was 10% better with a triplet compared to a doublet, though not significantly different. But it came with a toxicity of higher number of grade 3 and 4 AEs, mainly to do with myelosuppression. The median overall survival and progression-free survival was not significantly different. So I think maybe gemcitabine cisplatin itself is a good drug, and olaparib or any of these PARP inhibitors probably have a role in maintenance strategy. A lot of trials being run all around the world with PARP inhibitors. So I think to conclude, I would say that we should consider germline and somatic testing in all patients with pancreatic cancer. And we should consider olaparib as maintenance and not at the time of progression in patients with germline BRCA and PALB2. And I'm taking extrapolating PALB2 from the veliparib study, because if you listened to Dr. O'Reilly's talk at ASCO, she said that they have looked at the data with the patients who were on the GemCis arm. When they went on to veliparib, the median survival was 24 months, very reflective, very similar to that seen in the POLO trial with olaparib. So as Ankur very nicely said, most patients will receive actually both the effective regimens, GemNab, Pacli, and modified FOLFIRINOX if their performance status allows. The other thing I'm quite passionate about in GI cancers overall is having genomics review boards, especially at the time of progression. I think we should try and profile the patient's tumor to see what is the driver mutation which has made them recur. Thank you.
Thanks, Dr. Bhavna Siroi, for this wonderful talk and insight about the BRCA and the PARP inhibitors. There is a question for you from Dr. P. Suresh. What is the possible reason for no overall survival benefit in the POLO trial?
So I think it's So I think it is related to effective salvage options. I mean, when the patients would have progressed on the placebo arm, they would have gone on to effective second-line treatment. So I think that then negates the survival benefit. So that's why I think we are more and more as oncologists taking progression-free survival. But if you have an effective drug which is good, it would lead to overall survival advantage. But to look at that, they would have needed a bigger sample size. So we are not doing those studies anymore.
Dr. Bhavna, in the metastatic pancreatic cancer, we know that whatever you give the first line, most of the patients, they are not able to go for the second line.
Yes.
So I don't think that the crossover is a big issue or the big reason for not demonstrating the overall survival benefit. That's my thought process.
So yeah, like I said, if it was a very good drug, one would have seen there's no plateau in the curve.
Yeah.
At all. And I think it doesn't reflect real world practice at all, this trial.
So still I'm not clear in my thought process. Let's say my patient is BRCA mutation positive upfront metastatic disease. So what should I offer to my patient? FOLFIRINOX, gemcitabine cisplatin, or single agent PARP inhibitor?
So if a patient has a germline BRCA mutation, I tend to go with gemcitabine cisplatin.
Followed by maintenance.
Followed by olaparib, yeah. But nowadays we are already starting, by the time we get the results, we have already started GemNab, Pacli, or modified FOLFIRINOX. And I think only in a couple of patients I have changed it. But otherwise I've continued on whatever strategy I've started in, but made sure that I've added platinum if it's a germline BRCA. If I started with GemNab, Pacli, I removed the NAB, Pacli and switched to cisplatin.
So there is another comment from Dr. Vamsi Krishna. But if using a drug in second or third line is as good as in the first line, then why to use it in the first line at all?
So again, we have, all of us, Vamshi, have so many patients, who end up receiving, so I have currently a patient with metastatic pancreatic on fourth line. Again, this is all anecdotal. fourth line chemotherapy. There's nothing we found on NGS. So he's on Capox right now. So again, you know, this is all anecdotal. There is no evidence to talk about this, but most of our patients the performance status dictates everything, I think, for our patients.
I think it's a time to close this particular talk. Thank you, Dr. Bhavna, once again. Let's move to the debate. Debate in the resectable pancreatic cancer, role of the neoadjuvant versus adjuvant chemotherapy. And to start this, we have with us Dr. Vamsi Krishna, Senior Medical Oncologist from Apollo Health City, Hyderabad. So he will be putting his point in front of all of us in favor of neoadjuvant chemotherapy in resectable pancreatic cancer. Dr. Vamsi Krishna, please.
Thank you. Good evening to one and all. And as you can see from my title, I am pretty much putting it out there that it is neoadjuvant therapy in pancreatic cancer, not necessarily chemotherapy. And for me, it's an unequal fight. So there are certain debates which are not really debates. You may disagree, but well, accept the reality. This is not a debate. This is simply a fact that I have to just reiterate whatever has already been done. And I believe I've already won the fight. And in fact, if anyone wants to go back 1 hour and listen to what Dr. Shailesh told, a wonderful presentation, the first 10 minutes, he just basically told why I am correct in my debate. So when we talk of pancreatic cancers, only 15 to 20% are actually resectable. 30 to 40% will be locally advanced or borderline resectable. 45 to 50 are metastatic. So right away, when we talk of the role of surgery upfront and adjuvant therapy, it only applies to 15 to 20%. That's point number one. More importantly, in these patients who go for upfront surgery, Dr. Shailesh told us that in his data, that is 57% only had a R0 resection. This is not unique. This is not unique at all. In all the big trials, the rate of R1 has been anywhere between 20 to 40%. So we still do not know how to exactly find out our resectable patients. Yes, we have definitions. There are several definitions. You can follow the different societies. You can follow NCCN. You can go for resectable, borderline resectable, locally advanced, based on all these venous and arterial involvement. But end of the day, none of this is absolutely certain to tell us that we are going to get an R0 resection. Why is this important? Look at the SPAC4 data. I'm just giving one example. The GemCap versus gemcitabine monotherapy. Those patients who managed to have a negative resection, they had a significantly better overall survival. Otherwise, in a patient who is going to end up with a positive margin, you are really not doing any advantage by giving adjuvant therapy. So that proves my point. You need to give neoadjuvant therapy to ensure that your patients are going to get a negative margin. What else? There is at least 10 to 15% of patients who probably will end up having a micrometastatic disease. And if you undergo surgery upfront, very short time, they are going to have a relapse. Now, early treatment would probably help in eliminating or at least reducing the risk of these patients. What about the surgery? Now, again, the surgery sounds very complicated, very fancy. You remove one vein, put in one more, do grafts, etc., etc. But at the end of the day, it is a morbid surgical therapy. And for those patients who would probably derive no benefit from it, it is an unnecessary therapy. We have to increase the number of patients completing therapy. After Whipple's, there is a significant proportion of patients who would not be able to complete this therapy. We need time to improve the patient's performance status prior to surgery. End of the day, preoperative therapy can shrink the tumor, potentially improving the MR0 rate. Let us look at the trials. Now remember, look at what is written here. These are resectable patients. So if you use GemCis or RT or only GemRT or any kind of chemotherapy versus only upfront surgery, your primary endpoint of OS is better whenever you have used the neoadjuvant surgery. Your resection rates are better and your R0 rates are better. That is all that we want in a pancreatic tumors. What about neoadjuvant therapy in resectable alone? Now remember, this is chemotherapy, this is chemoradiotherapy, or it is neoadjuvant chemo followed by adjuvant chemoradiation. Everywhere, the benefit is seen when you have neoadjuvant therapy, resulting in R0 from 80 to 90% and a median OS which is much better than what we are normally dealing with. So is this all that we need to look for? Just look at this one example. This is the NeoLab study, where they tried to see not just giving nab-paclitaxel gemcitabine alone, they gave nab-paclitaxel gemcitabine plus FOLFIRINOX. The primary endpoint of conversion rate increased significantly. Overall survival improved because those patients who could undergo resection did much better. Yes, I know Dr. Amol is shaking his head and saying this is LAPC and we are talking of resectable. Well, I have already shown you what the benefit of resectable is. Yet, let me present more data. There was one paper which was a propensity matched analysis, and they found that the median OS was better by 9 months with a p-value of 0.02, hazard ratio 0.65. Numbers don't lie. This is what really is clearly saying that neoadjuvant treatment is the way to go for resectable pancreas also. Is that enough? What we should actually be doing and following now is not just neoadjuvant therapy. We should be going for TNT, that is total neoadjuvant therapy with FOLFIRINOX or with chemotherapy, followed by radiotherapy. And when you do that, the patients who are undergoing resection, there the R0 rate goes up to as high as 97%. Numbers are small, but then all pancreas, that's what we see. Okay, let me look at the other side of the picture. What is the benefit of only adjuvant therapy? Look at this paper where you had all the trials, including up to 2010, 15, the SPAC3, the CONCO. Everywhere you get some non-significant trend, no difference in PDFS OS, or improved median disease-free survival, no improvement in overall survival. What do we do next? We go for a meta-analysis. Now, there are several meta-analyses. This is the latest, 2020. The benefit was seen only in S1, but there also results are yet to be determined, and we do not know if adjuvant therapy helps anywhere. What about NCCN? NCCN tells you if you don't have high risk factors, go for surgery. But what are these high risk features? Imaging findings, highly elevated CA 19.9, large primary tumors, large nodes, excessive weight loss, and extreme pain. I can tell you all of us treating pancreatic cancer, many of our patients, most of them in fact will fall with one of these high risk features. And that's where you need to go for a neoadjuvant therapy and not an adjuvant therapy. Yes, you have other guidelines which say that if it is locally advanced, you should simply go for chemoradiation or chemo alone. But here also, we now have seen that FOLFIRINOX is helping. There was a meta-analysis which showed that the resection rates could actually be as high as 15 to 20% in a locally advanced pancreatic cancer, not a resectable alone. So, again, showing you a systematic meta-analysis. Dr. Shailesh showed one which was done in 2018. This is done in 2020. And what they showed is for low borderline resectable, definitely there was an improvement in OS. There was an improvement in the R0 rate. For patients with resectable, again, a significant subset did have an OS benefit, wherein the others did not have an OS benefit. We have to understand that identifying that subset is still not something we can do with full confidence. So for me, this is the pathway to follow. Even in a resectable pancreatic cancer, go with chemo or chemoradiotherapy, reassess, go for surgery, and then consider your adjuvant therapy if at all. So Dr. Amol, to explain, give you a sort of an example you can understand more clearly, never go to a gunfight with bringing only a knife. You'll be heavily outgunned and outmaneuvered. So ultimately, the truth prevails. So thank you.
Thank you, Dr. Vamsi, for the wonderful talk and putting your point in favor of the neoadjuvant treatment. So let's hear the view from our colleague, Dr. Amol Patel, in favor of the surgery followed by adjuvant in similar setting. Dr. Amol, please. He's from Mumbai, INHS Ashwini Hospital. Dr. Amol, please. Is he available, Dr. Amol?
Yeah. I'm trying to share my screen.
Yes. We will give you enough time. Don't worry.
No. I don't need enough time. 5 minutes is good enough. So as usual, there is too much talk. There is less of data. Whatever the data is shown is all about phase 2. And a lot of, fancy stuff talked. But let's talk what is the truth. So I have to talk against, which I generally do not like, but see, I have to teach again what is the definition of resectable. It's a very clean definition. Surgeon sees the case, radiologist help them, and they take a decision that it is a resectable disease. And then, what confusion came is out borderline resectable, 180-degree, 90-degree. Some surgeons are comfortable, some are extraordinary. And then there is a study of NACT in borderline resectable, but those restless mind go beyond it and now thinking about putting the NACT in resectable disease. So is there any doubt about this slide, Dr. Vamshi? This is a systematic data. This is the data which evolved over last 2 decades, step by step, not by the reckless mind. There's a disease and we have to go like that, do this, that disease, GEM-NAB, FOLFIRINOX, everything you give, whatever you want to do. This is the data. You have to go systematically, step by step, one by one, and that's how we have reached up to PRODIS trial. In the PRODIS trial, the FOLFIRINOX was compared with single agent gemcitabine and see the phenomenal results. Overall survival 54 months in resectable pancreas. And as on today, this is the standard of care. In spite of 70% of the modification took place in the patients when the toxicities were monitoring, but still the benefit was there. So there is no ambiguity, there is no argument, there is no kind of any comment on this systematic evolution of data of adjuvant therapy in pancreatic cancer. So there is no fight for me. This is a standard phase 3 trial. Whatever you have shown, these are all phase 2, and many of them couldn't complete the accrual also. So I have already mentioned about the PRODIS style, and you see this how nicely the graphs are separating, and the 3-year survival rate is never heard about in the pancreas is around 65% versus 48% with the gemcitabine. So what are the benefits of neoadjuvant chemotherapy? So as by mentioning this and saying this all about adjuvant benefit, it is a standard of care. There is no ambiguity. Now, what are the benefits mentioned? And typically, he has today fall. Generally, Dr. Vamshi don't fall in the trap, but he has fallen in the trap today. Now, see what is my trap? Downsizing. What is downsizing? Why you want to do make the disease which is already downsized? So you did it in a borderline resectable. Now you want to make it resectable further. Here comes the question about what are the response rate. The concept of neoadjuvant chemotherapy was very well established in breast cancer, and perhaps because of that, many other areas in the other organs, the NACT is evolving. But what we're going to do when your majority of the responses are stable disease or progressive disease? Only 25 to 30% of the patients are going to have some kind of a partial response, and you mean to say you are making that resectable further resectable? Is there any point about that? So I do not take this downsizing and the margin negative. Then comes about the question about the tolerability. I'm very surprised. He has not touched upon this, but everybody has shown this trial. The total neoadjuvant, what is said of the 43 patients, is just a small number study. In that, 80% were able to complete. That means the 20% are still are not be able to follow your protocol. So this is of the available data. This is the only prospective study which is addressing the toxicity. So it is not that easy to administer the complete neoadjuvant therapy, or there are no added advantage to it. Then also about the surgical morbidity. So there is no difference in surgical morbidity and mortality in both the approaches. There is a nice meta-analysis, and it says that you can go with both the way. And I think this was the only gracing point in this topic. Otherwise, all the topic do not give any bigger evidence for suggesting neoadjuvant chemotherapy in resectable pancreatic cancer. The phase 3, this is the only phase 3 trial, and which was studied till date, and there's the pre-operative chemoradiotherapy and the immediate surgery. Here, there will be argument that only gemcitabine was used, but anyway, this is the only truth available in the form of phase 3 trial. Till date, there is no such good evidence to practice the neoadjuvant therapy in absolutely resectable disease. What was this in this trial also? There was no overall survival benefits. That means this phase 3 trial failed to show any advantage of preoperative chemo or chemoradiotherapy. Then S1, a slight talk about the S1. It's fine. Have gone through this trial. It was two-part study. The phase 2 was converted into phase 3, and I generally do not take when the evidence is created with the fragments. And again, the simple, we call it in Hindi, basically, angur khatte hote hai. I don't want to, complete the phrase here, but we don't have any access to S1. So please do not talk about the S1 in this forum today. Again, a very interesting study I came across while preparing, and I wanted to give a big fight to Dr. Vamshi. See, what is this study? It was published in 2016. What it says, time to initiation of adjuvant chemotherapy does not impact survival. So in resected pancreatic cancer, whatever the data they collected from the registry, in that whether the chemotherapy is started before 12 weeks or after 12 weeks, it is not changing the outcomes. So what the concept here is, what we need is a more better understanding of the disease and a more better chemotherapy regimen even than the FOLFIRINOX. So these are the curves, and it is compared to the surgery alone and the adjuvant therapy, 12 weeks and more than 12 weeks. It was not statistically different. What are let's see the ground realities. What happens when you plan the NACT? Is that so simple? In the majority of the center across the country, you get some kind of a hitch towards getting the tissue diagnosis. Many times you need ultrasound guided, sometimes US, and repeated attempts we have all witnessed. And there are false positives and false negatives. And there is a data which says that 20% eventually fail to establish the diagnosis. And what I feel here is the curative intent treatment is delayed. Nicely, the ASCO was shown. The ASCO, the NCCN was shown. What do you think? What about this high risk factors? Very high CA19-9 levels, large primary tumors, large regional lymph node, excessive weight loss, extreme pain. That means they are poor PS patients. And now where did you get these high risk factors? Is there any systematic study you did with that? Many a times the NCCN guidelines, they are at random, they are made by some expert group. But I think when you go in details of those J, M, N, and whatever the cross reference, and sorry to say, Dr. Vamshi here in discussion, they have not discussed not a single trial. So I would not agree to you on this NCCN recommendations. It is absolutely imaginary. It does not support the data. It has not come from any data. In fact, even in the adjuvant setting, very high level, the cutoff is kept around 190, and such patients are excluded for enrolling in the patients in the adjuvant setting also. So that means these are very, very poor prognostic areas. And if certain patients are there, I would certainly say this is just imaginary thing. If you are wanting to it should be under clinical trial, but you cannot just go as per the NCCN guidelines. ASCO, it is absolutely against it unless they say it's a clinical trial, and ESMO did not utter a single word on neoadjuvant. So conclude here is NACT in resectable pancreatic cancer, 20% of the patients going to progress while on NACT, 20% there is a tissue diagnosis issue, there is always inconclusive, and you had it and you are losing the crucial time. And as I have shown the data, 20% are not going to be complete the protocol. So you don't try to build a wall, and you unnecessarily don't put your head on the wall. As have been already discussed with the previous speakers. The microenvironment is so sad here. There is a difficulty in penetration of the chemotherapy agents, and somehow it remains the chemo resistance disease all along. So you may be thinking, Dr. Vamshi, that you may be runner-up today, but no, you are not runner-up even. Okay, that's it. I finished. Thank you. Thank you for listening.
Thank you, Dr. Amol, for vehemently attacking our friend Dr. Vamsi. So out of that, we need to give him the 2 minutes rebuttal to make the points more clear, and so that we can drive some conclusion regarding the neoadjuvant systemic treatment, including chemo plus minus radiotherapy. Dr. Vamsi, please.
I thank you, Dr. Amol, for bringing out those points and for very vehemently defending your position. That's what we would do in any debate. Simple thing is, we cannot just stick to going by what has happened in the past and ignore something that is going on, and simply rejecting all trials which have shown a 20 to 30%. Remember Dr. Shailesh Srikhande's figure, only 57% of patients get an R0 resection. That's real life, that's India. You can talk and think about whatever else you want, that's what happens. And 40% of patients will not get an R0 and will not get a good result. Yes, you can say that NCCN doesn't want to do something for other things. That is just trial by jury. Just because they have a lot of issues in NCCN, which I myself accept, we cannot say that they're wrong every time. This is one place where they were very correct. These are real practical situations, and these we need to address. So to conclude, I would still believe that neoadjuvant therapy is the way to go. I'm willing to sit down and argue with you whether it is neoadjuvant chemo alone or neoadjuvant chemo plus radiation. That's a debatable topic, but definitely it is better than adjuvant therapy.
So I think that one thing is very clear to all of us, those who are joining today, that we really enjoyed this debate. It made the things very clear to us. And yes, we do agree that neoadjuvant treatment as on today is for the select patient, irrespective of the R0 versus R1, number of the patients who receive. And the important point that when you start the adjuvant therapy, it is not widely practiced, at least with the available combination of the chemotherapy with the response rate to the tune of 30 to 40% maximum with the FOLFIRINOX protocol. So select patients, yes, in the resectable group of the patient thinking the bulky disease or the large size nodal disease or the pain or the weight loss and very high CA19 as given in the guidelines, maybe that you are able to select the certain point. That's my take home. And with this, I think we should close this debate here and let's move to the next session as we are short of the time. And thanks again, once again to both the debaters. So now I invite Dr. Amit Rothan for the panel discussion. Dr. Amit is from the Bangalore, our senior medical oncologist. And Dr. Amit, you are here?
Yeah. I'm
so
here.
by the time Amit arranges his things for the discussion, let me invite our panelist for him, Dr. P. Suresh. Is he available? He is senior medical oncologist from the Army Hospital Research and Referral, New Delhi. Welcome,
Yeah.
Dr. P. Suresh.
Yes, I am available. I am available.
Dr. Ashay Karpe, again senior medical oncologist from SL Raheja Hospital, Mahim, Mumbai. Welcome, Dr. Ashay Karpe. Dr. Suhas Agre, medical oncologist from Asian Cancer Institute, Mumbai. Dr. Anubha Bhartor, medical oncologist and hematologist, HOD from Patel Hospital, Jalandhar. We welcome you, madam.
Thank you.
And Dr. Vivek Agarwala, medical oncologist and from Narayan Super Specialty Hospital, Kolkata, and Dr. Vikas Talreja, our good friend, medical oncologist, recently moved to Regency Hospital, Kanpur from Delhi. So with this, I invite all the panelists and I hand over it to Dr. Amit Rothan for the pancreatic cancer panel discussion in the metastatic setting.
Thank you, Dr. Naresh. Good evening, everyone. So we have had some wonderful discussions, some wonderful talks, and after that, a very passionate panel. So let's get down to trying to talk of what we do in clinical practice. So the amount of data is there, right there, but the amount of phase 3 data is limited. And when we kind of look at the amount of data sets you have in pancreas, they're very limited. But eventually we have to look at how we practice and how we use this data in clinical practice. So just to put up a case so that we can start debating and talking about what we do in clinics, here's a 62-year-old male with history of diabetes, no family history, good performance status. diagnosed with adenocarcinoma head of pancreas. He has multiple liver lesions. They're not very big, but there are multiple of them in bilobes, both the lobes. They has a mental stranding. The blood reports are okay, and he has a high CA19-9. So let's start off. Dr. Suresh, I wanted to discuss about testing first. So what all do you test for in such a patient who comes to you in the clinic?
Yeah, presently or till recently, I was not doing any molecular testing, of course, and so I just introduced it into my practice now only to check for BRCA. As far as homologous recombination with the complete panel is concerned, still I have not started doing that on my patients.
Right.
And as far as the complete NGS panel is concerned, that also I am yet to initiate in my patients. So as of now, only germline BRCA I'm doing.
Right. Okay. So germline BRCA is what you do. Dr. Ashay, what about you? This is at the start of presentation. Dr. Ashay? Okay. Dr. Suhas, could I come to you?
Yes. So as we can see now with the various guidelines coming in and various ASCO and all NCCN they are recommending. So early testing would be the key in the management of the metastatic pancreatic cancers, and that too with the germline BRCA testing, and if possible, the somatic alteration testing by the NGS would be recommended.
Okay. But in practice, have you started doing testing at this time frame?
Yes. So whenever the patient can afford, I do counsel them to get an NGS test, because that can widen the spectrum of the various treatment options. And definitively, germline BRCA would be the one thing that we generally advising.
Right. I think all of us in practice have started doing that, sending germline BRCA at least minimal. Dr. Anubha, you kind of have started doing the same thing.
I think for those who can afford, then I would do the germline BRCA testing or the NGS, because you can now get that panel which has the extensive testing in one go. And the correct answer is also to get an MSI, although honestly I have not been getting it done right now.
Right. Yeah, that's another point with doing testing for MMR or MSI testing if you have tissue initially. So I think all of us are kind of clear-cut, have started doing germline testing. It's a recent change in practice. Earlier, we were not bothering about it too much. We just used to start off in treatment and look when they progressed and start thinking of testing. So I think this is kind of consistent, and we should be doing germline testing. I would like to.
Can I put a point in front of all of you?
Yes, Dr. Naresh.
Do you really discuss with the patient before doing the MSI or BRCA that what implication or what sort of the treatment and its cost will be there if these tests come positive for you tomorrow?
Yes. So who will take this? Dr. Vivek, you will take this?
Yeah. So, sir, we do discuss regarding the PARP inhibitors as well as the cost. But we must understand that not only if a patient who comes BRCA positive is a candidate for PARP inhibitors, but then they've also become a candidate for platinum based treatment. So that's why it is not just important to counsel them regarding these tests, because there is a inhibitory factor, because the PARP inhibitors are too costly. But sometimes if they come as positive, then we do need to give them the benefit of early platinum based chemotherapy.
Right.
So that's how I think it'll help.
Correct. I think the point you're making is very correct, but I think one more point, I don't know if Dr. Naresh was pointing to this. What happens is the hereditary component of explanation and talking in clinics and explaining about the whole downstream pathway becomes very difficult. And I think that takes up a lot of clinic time. So for me, I think the testing and for treatment is easy. I don't think that takes up too much time, but when you have to test and explain about the whole heredity of the family, that's something very time consuming. Dr. Vikas, what about you? What do you think about this?
So there is definitely a disturbance. I don't know where it is coming from. I would like the host to mute those things. For one very important point, I must say that Dr. Vivek has brought to it that nowadays BRCA testing, because of probably the breast cancer awareness and the pancreatic awareness thing, has drop down to around 8,000, 9,000 on a germline testing. That could easily tell us whether the patients are platinum sensitive or they are insensitive. And off the records, various formulations of olaparib are available. So definitely it gives us at the end of the day an options. And I would also say that at the end of the day, it is very important at baseline what we do, because it's not going to determine our first line treatment. It's also going to determine our second line and third lines, especially with a metastatic pancreatic cancer, where we know the treatment options are very limited. So I would definitely give my best shot at the first to go for the NTRK, go for the MSI, go for the MMR, go for the PDL1. I know the chances of these coming out are slightly less than the other tumors, but then definitely if there are, we need to hit upon. And then there is a beautiful option of clinical trials. So we need to also look to those
So
patients.
so you are in favor of somatic testing where you're doing a whole NGS and looking at everything. No, this is
Yes.
ideal. This is ideal. My restriction is always tissue. You know, we never have that much tissue in pancreas to do the whole somatic testing quite extensively, though we would like to do it. But germline definitely is easy and straightforward. So that's something we all say, we do it off and send it immediately. Yes, if we have good amount of tissue to do a somatic test, we would do it.
Dr. Rathan,
yes.
Suppose your patient is not the metastatic upfront presentation. This is a patient who operated and now the mets. So you would like to use the old tissue which is available in ample quantity from the Whipple surgery, or you would like to do the liver biopsy again?
So here I think we can go ahead with the old tissue. So again, if you look at the whole history of how pancreatic metastatic developing, how many are somatic mutations developing later, the difference is not big. It's not like how it was in other cancers where we say the big difference between germline and somatic. So
Yeah,
all the data which we are having is much more germline. The data of somatic is just a little bit more. So I don't know whether we will really make a big impact by doing a fresh biopsy and using the tissue. But again, we keep hoping we will hit something, you know. But in pancreas, the reality is there are only these three things, you know. We keep talking of PAP, BRCA, we talk of MMR, and we talk of NTRK. And out of these, I don't know how many of us have seen MMR, NTRK ever, or how many of us have seen MMR in pancreas. So I think I think we will slowly learn as we start doing more testing, like Dr. Vikas is mentioning. But I think somatic testing is not going to be easy in pancreatic cancers. We are always going to run short of tissue for this. And secondly, one point is blood testing, doing blood-based NGS for pancreas really is not very good. I don't know, really, even if we do a garden-based NGS for blood, we're not going to really pick up too much information. So if we have tissue, I think we should look for that. So I think all of us kind of now have moved to testing first line, and we test as early as possible, and we test for BRCA germline. And yes, if we had tissue, we would look for more. So now let's look at what our first line option would be in this kind of a setting. Let me start off again, Dr. Suresh. How do you think about in this kind of a patient, and what are your thought processes when you're choosing first line therapy?
So I personally am convinced that FOLFIRINOX is the best regimen that is possible as of now. So my concern would be tolerability, and so I would look at the patient characteristics, mainly his comorbidities, his age, and other issues that are with the patient. And any patient who I feel can tolerate therapy will be considered for FOLFIRINOX-based chemotherapy.
Right. So you favor FOLFIRINOX more than
first line would be FOLFIRINOX-based chemotherapy.
Right. I think okay, yeah, that's if our fit patients. But are you comfortable with the ports and the pumps and sending them off home, and that's perfectly okay, right?
Yeah, we have a good system, so I am comfortable. We put in a PICC line or a port and use the pumps and send the patient home. Actually, we have been sending the patient home.
I think that's the best way to do FOLFIRINOX if we are able to do it comfortably with the port and the pump. Dr. Suhas, you are so I get these two kinds of things. You know, I have these people who are pro FOLFIRINOX, and I have these people who are just anti FOLFIRINOX. We have a lot of these debates in us sometimes in our clinics, and we end up with these two kinds of people, you know. So Dr. Suhas, pro FOLFIRINOX?
So I think maybe the what is most important factor in deciding all these would be the first will be the performance status, and second will be the what is the status of the comorbidities, where they are controlled or uncontrolled, and based on that maybe we can select. And if we are finding any kind of HRR deficiency, then we can select basically the platinum base. And maybe if the patient is fit enough and with controlled comorbidities, we can opt for the FOLFIRINOX. Otherwise we can use even the gemcitabine and the cisplat also.
Right. So my reluctance to understand this is always you have started sending germline now, and that germline is going to come 1 month later. That report is not going to be in our hand to choose a platin. So I don't think we'll really have that information at hand to choose first line platin. If it's giving FOLFIRINOX, it's okay. Oxaliplatin is there, but Gem-Nab-Pacli becomes easier. So that's a very difficult way of choosing, saying that we'll get our DNA repair defect information on time. Dr. Anubha, what do you think?
So, of course, I would like to use FOLFIRINOX in majority of my patients, but the sad truth is that most of my patients don't end up getting FOLFIRINOX. And it's just because most of, when you talk to them that you're going to get the pump and you have to get the chemo port placed and you're going to go home with it, and these are the side effects. And we have to acknowledge that FOLFIRINOX is going to have a lot of side effects with whatever you do. I mean, they're going to. So if I am using FOLFIRINOX, I don't do the bolus. I dose reduce upfront, and then I kind of walk my way up to the higher doses. Like that's how I've been doing it, so that I don't, what I have also realized is that whatever the data is, our patients have more side effects.
It is a toxic protocol, no doubt about it.
So
at least in comparison with Gem-Nab-Pacli.
Yeah, so yes, I do use a lot of FOLFIRINOX, but I dose reduce upfront. I don't give boluses, and sometimes I will admit the patient in the first time so that they're comfortable with it.
I think it's perfectly fair. I think all of us have found out ways to make our patients tolerate FOLFIRINOX better. When I say modified FOLFIRINOX, I mean we modify it according to our convenience. It's not modification which the international guidelines follow. So I write in my discharge summary, I've given modified FOLFIRINOX. That's my modification, and I'm perfectly okay with it. And my patients, as long as they can tolerate it, is good. So I agree with you. That's the reality of our practice. Dr. Vivek, I wanted to ask you, if you did Gem-Nab-Pacli, so do you do Gem-Nab-Pacli for your unfit patients?
Dr. Amit, can I interrupt you once again? There is a question in the chat box from Dr. Sandeep Jasuja, medical oncologist, Jaipur.
Yes.
What is the role of doing enzyme deficiency? Yeah.
So you're talking of
enzyme deficiency testing before irinotecan.
Okay. So looks like Dr. Vivek gets all the questions from the audience.
So I think doing the UGT1A deficiency that is actually done for irinotecan is something that we hardly do in clinical practice until and unless there is a very unexpected toxicity or a severe diarrhea or something to irinotecan. So this is something I don't think it is even recommended. Doing a DPD deficiency testing when you are using 5-FU is something that is actually recommended. There was a Lancet paper showing that doing that can really make a difference, and there are certain heterozygous DPD mutant patients in us because that percentage is nearly around 8 to 10%. So probably 10% of our patients are going to be DPD mutant, and I think DPD deficiency is one test that probably we would do if possible.
So I kind of theoretically you are correct, I would say, looking at how the data sets are, but I practically don't agree with this, and I don't agree with both of it. Doing for irinotecan or doing for 5-FU.
Yeah, so I totally agree with you, sir.
In practice,
the amount of irinotecan based tests we never do until and unless, but this is something that some centers do practice, and if I have a patient who is I'm very cautious about, then I would recommend it. I usually go ahead and start my FOLFIRINOX, but my
reluctance is I don't agree with that percentage. That 8% which you mentioned is very unlikely. I would say that.
But there has been data from Tata Hospital Mumbai also, which the percentages are quite near to that. So
see, the only thing is that
you will not get it.
So no clear-cut guidelines. There are no clear-cut guidelines. How to really modify the dosages. Based on how they are quantifying actually DPD. We are just saying heterozygous, homozygous. I think at the end of the day, we go by clinical things. I think so. I think if the patient is having maybe too severe toxicities with maybe even simple as if we are considering for folfirinox, even is valid for folfox also. Like CA colon. So I think that makes a sense. Definitely, there is a data from TMH that it can vary from 18 to 20. I mean, 22%. They have as high as, because this was done for head and neck population in DCF.
So the
So, but
reality
still, I
of
feel
Yeah, so there is data from Dr. Vikas Ostwal also in the GI cancers.
Yeah.
Yeah.
So
They have also
I
given their
agree about
data.
I agree with the data set of the percentage, but I disagree with how much toxicity do you see in clinical practice? Do you see that number which you're talking of 8%, 10% having that severe toxicity? Because if you would be DPD efficient, the toxicity will be very, very severe. So we
So
don't see
Dr. Amit, the heterozygous patients, the toxicities are really not that
so why
high,
do it? So why
that
do it?
severe.
So why do it?
But again,
Remove your patient.
Homozygous are 1 or 2%.
sometimes it is
I would agree
unpredictable.
with that 1% statement. It's 1%, and you can manage that
Yeah.
clinically. So you can choose clinically with what my feeling is. Okay, I think we'll move forward. I wanted to ask this to Dr. Vikas. If you started Gem Nap Packley, and if you then got the BRCA mutation germline positive, now you know it has to be platinum exposure. What do you do for such patients? Do you change treatment, or do you just continue it because you get the report after 1 month?
So first thing first, there are three things I would like to say. For the first thing, the folfirinox, I believe, is for dinosaurs, because you give an irinotecan. Original one is 180 milligram with a 400 milligram IV bolus. I never ever. I've tried giving it to few, and I have burnt my hands, fingers, mouth with it, and I have understood that folfirinox is not the regimen for an Indian patient, especially in a metastatic pancreatic cancer. The modified version also, I feel, is not the ideal one, because I tried the modified one also, and the tox Ts were still. So after the max the patients could go up to was the 2 cycles, and that was the regimen it has, because you invariably modify the doses, and then you find out the patient does drop out after
So
the.
I kind of think what you're saying is correct in general, but you with years of using folfirinox in pancreas. So I have patients. So we have about, maybe I could tell you, a cluster of patients who have crossed a year of folfirinox easily in the metastatic setting.
Yeah.
And you can count the number of cycles. Would be like they would go on, take 12 folfirinox, remove the irinotecan, continue ILF, again remove the oxaliplatin, continue ILF, and you would do this for years sometimes. So
I agree that yes, there would be.
modify it. I agree, but I don't think we should say modified folfirinox is toxic for Indian patients per se. Everyone, I think the generalization.
So the actual modified was also that's the Indian modified folfirinox, which we are discussing, where we
Anyway, because
remove.
the main question, BRC agencies.
So the third thing is, yes, Gem-Nab-Paclitaxel is a very comfortable and tolerable version, and if a patient is clinically responding to Gem-Nab-Paclitaxel and you find a BRCA mutation, the first thing is to find his affordability. If we have advised him on the first day that go for the PARP inhibitors upfront. If the affordability is not there, then definitely I would switch over to from Gem-Paclitaxel to cisplatin. In view that we know that invariably the regimen is not going to be much of useful. The curves aren't that much encouraging. So the platinum definitely is going to have a much more clinically meaningful benefit, and that's why we would be doing it for
Right.
most of our patients.
Dr. Amit, can I come in?
Yes, Vivek.
Yeah. Dr. Amit, regarding Gem nab-paclitaxel regimen, you see, Abraxane is not available. And the real question comes that what nab-paclitaxel are you actually using? Because so far as my experience with the Gem nab-paclitaxel, it hasn't been really great. I have tried so many versions of nano paclitaxel and nano albumin bound paclitaxel and albumin bound paclitaxel, but the results haven't been satisfactory.
Okay.
And one thing which I have observed in my patients is those patients who actually have benefit from Gem nab-paclitaxel, they would continue to derive the benefit from a single agent gemcitabine maintenance, that is that I give them.
Yes,
So
that's
I really doubt how much is the paclitaxel adding to this. So
so
I have real reservations regarding
Vivek,
Gem-Nab
that
paclitaxel
issue is
regime.
never going to be answered because now you're never
And
going to get Abraxane
yeah,
in
and
India.
my question to everyone is, which NAB paclitaxel is actually are you using and you are getting the benefit? Please tell me about that.
So this is something which gets very controversial, but I can tell you. So there's so we're not going to get Abraxane, so we can as well forget that. You can yourself see you're using nab-paclitaxel, which different ones in different settings in different cancers, and you're seeing the response. So I don't think we can say just because the nab-paclitaxel are generic they don't work. I don't know, they've never been compared, so we'll never be able to say
Yeah,
what
but sir, I mean,
effectivity
which
versus
which
Abraxane.
NAB paclitaxel in pancreas are you using and you are getting the benefit? I just want to
I
know
think
that.
we have tried varied ones, and I'm sure we are all having responding
Yeah.
patients. Would you agree? Suhas, do
Yeah.
you get response?
Yes, definitely.
Yeah,
It depends upon which symposium we are talking to.
okay, I think we'll move
I think
forward.
we will
I don't
just
think
go
we should
forward.
get
Yeah.
into this debate of which snap packly. We all use various snap packlies and we have response. So I think that's fine. Doctor, uh, uh, one quick point I wanted because Ankur had brought this up. He showed that phase 2 data, which was so intriguing. Gem, nab-pacli, small dose cisplatin. You can do it as day 1, day 8, every 21 days or something like this. You can actually get that high response. You can get platinum exposure also, and you have the longest survival. And these patients would be ideal to move into the BRCA space later. What are your thoughts, Anuva? What do you think?
I think it something that could be attempted.
Yeah, I very intrigued by that phase 2 data. It had the longest median OS. It's phase 2, I agree. And we do gem nab-pacli with small dose cisplatin in various other cancers. So that's something you can always attempt.
Yeah,
I have
I'm
heard
just worried about the peripheral neuropathy. So because you're using paclitaxel and then you're using cisplatin, so I think this is going to be, these patients are mostly diabetic, and then you are having paclitaxel and
yes, we'll have
cisplatin.
to be careful. As Vivek, you've said that we'll have to be very careful in doing.
Dr.
But I
Amit,
think
can I put my experience here?
yes,
This
yes,
3 drugs combination I have attempted in the gallbladder malignancy. It's not so easy to administer.
correct. I would agree with you. It's going to be quite toxic. There's no doubt
Yeah.
about it.
Though it is a breakthrough, it increases the response rate to more than 40%.
Correct, correct.
Yeah,
I
but
think
it's
you can
very, very,
selectively.
it's something like folfirinox.
Right. Okay. So we'll have to be very careful. Now, these are the first time factors. We all discussed this. All of us have talked about this. And this was one real world data which we got last year, maybe 2018 publication, look from the US, which they had looked at folfirinox versus gem nab-pacli. And they kind of said the median OS was the same, but this is real world retrospective data. So moving on, depending on what do you do for maintenance? Suresh, what is your maintenance protocol if you started folfirinox or if you started gem nab-pacli, both ways?
So if I have started FOLFIRINOX, though the recommendation is either I think FOLFIRI or 5-FU leucovorin, most of the time, to say the truth, I end up using capecitabine as
Right.
maintenance.
Right.
So that is the truth. And if I have used gem nab-paclitaxel, I frankly have not used maintenance after cycles of gem nab-paclitaxel.
You stop treatment?
Yeah, I have stopped treatment and given them a break sometimes, and or again I have switched over to capecitabine only as a
Right.
maintenance.
I think capecitabine is a good drug. Dr. Vikas, what do you do when you go through both these regimes?
So the contribution of irinotecan to the efficacy of folfirinox is always a matter of debate for me. I would definitely immediately after 8 cycles, I will remove the oxaliplatin. If the patient has any issues coming, then 5-FU leucovorin to me is as good as capecitabine, and I would put him on the same regimens as Dr. Sujay sir has told.
Right.
People also tend to with wells, and I would definitely put them with a smiling face that go on capacitamine maintenance, and then uh, review that. That would be also my similar plan.
I think all of us are thinking the same way. Uh, for us, it's the same thing. Only thing, if the port and the pump is already there, so then I kind of just continue Leucovorin 5 or ILF. But if there's no port and pump, then it becomes kind of very, very this thing. And of course, all patients want gap. So capcitabine turns out a good regime for all of us. Dr. Suhas, do you do the GEM NAP-PACLI, the 2-weekly regime, which the US people talk about a lot as long-term maintenance? They say that's equally as good as the weekly regime, which we talk about. And they say that in pancreas, you can make patients continue much longer by doing the 2-weekly regime.
I think that can be a very good option to try with if the patient means that will give us some relief for the patient for a frequent visits also, and maybe we can keep kind of maintenance treatment. Even what I do in my practice is that I try to give maybe once in 3 weeks or once in 4 weeks, even the gemcitabine alone maintenance kind of treatment also.
Correct. I agree with that thought. Sometimes gemcitabine single agent is a good drug sometimes. Dr. Ashay, what are your thoughts on GEM NAP-PACLI neuropathy?
That's fine. So NAP-PACLI, though we are saying, but with NAP-PACLI, I'm seeing a lot of neuropathies, peripheral neuropathies. And especially somebody has received maybe follifirinose before. First line is still okay, but some post follifirinose, already oxaliplatin, and so a lot of peripheral neuropathy. I mean, though we say, but again in the second line, again it is not really easy regimen. When the performance status is very low or something like that. So whenever maintenance part is usually comes there, usually I prefer single agent gemcitabine rather than continuing with the nab-paclitaxel of it.
But all of us agree on giving maintenance. So I think that's one thing we all try to give maintenance as much as possible, except when it becomes really bad. Otherwise, we all agree on maintenance. So with that, I think we'll just go up to the POLO data and just take up inputs. Dr. Vivek, what are your thoughts on POLO? Do you think this is sort of change of practice for you, or are you one of the thought processes that this trial didn't have a placebo? So there's a criticism there, of course.
No. I think in maintenance, placebo arm is a justifiable arm, so far as maintenance is concerned.
But
whether you talk about ovary or whether any condition.
All of us just now said we will all give maintenance. We will not have a patient without maintenance. That is always.
And I think this is like something proof of a concept kind of a data where you saw that if you are BRCA mutant positive, then whether it is breast, whether it is ovary, or whether it is even pancreas, this drug works. And yes, if patients are affordable, then I totally believe in this data, but I haven't had a patient yet whom I have been able to offer.
Yes.
So I don't have any experience.
Yes, clearly. Dr. Vikas, you have any criticism of the trial, or do you want to, or all for it?
Yet to find a BRCA positive pancreatic cancer right now throughout. So I would say that trials looks interesting, definitely encouraging reports. Yet the incidence of a BRCA mutation in a pancreatic cancer, I have to yet to report to.
Right. Okay. Dr. Anubha, what are your thoughts?
I agree with you that they didn't have a maintenance, which makes it a little tricky to compare, especially given that there was no OS. Then there was another interesting thing which they had pointed out in the discussion was that because these are the patients who are BRCA positive, they tend to do better. And there were 10% of patients in the placebo arm also who were alive at that 2-year time period which they were talking about. So does that mean that this is a population that's going to do even if you had kept them on just chemotherapy alone them or maintenance, they would have still done better.
So how did you know, Anubha, what my next slide was?
Oh, okay.
It's amazing. That's exactly what I wanted to bring out, and this is a point you brought out very well. So we know the HRD deficient patients, they are going to do very well, and these are data sets you have seen the OS and PFS benefits with platinum. And we know these patients can respond very well to platinum. So the question can always be, if you treated these patients with platinum long term, they would probably do still very well. So I kind of think it is teaching us we need to offer them platinum. So we need to find them and give them platinum. But of course, olaparib definitely opens up one more arm for our patients. So we will definitely say it is a positive trial that way. But I don't think we can clearly replace every platinum drug with this and say we should do this. Dr. Suresh, what are your thoughts on this? How do you interpret this?
I am worried about two aspects of this trial. One is that despite having a median duration of response of almost 24 months, which is mentioned here very significantly, So with that kind of median duration of responses, those are the kind that are seen with immunotherapy in other cancers. So there is very good overall survival benefit in other cancers. So I am very surprised that there is no overall survival benefit with that kind of responses. So that again makes me wonder, to your point, as to whether it is just natural, good history, good biology of the patients, which is affecting the survival rather than olaparib per se. So, and number two is the cost effectiveness of this drug. I feel is as at present is really bad. So cost effectiveness wise, I would put this drug very low down below.
Right, right. So cost is always the major issue when it will come to debates of olaparib. But I kind of agree with you. It's the platinum which also does the trick, and that's something we should never forget for our PARP inhibitor, for our BRCA positive patients. One question to Dr. Suhas: what would you do if you got BRCA negative, but you ended up getting an ATM mutation? We recently had patients, and there was a debate in the pancreatic section. Would you offer them an ATM mutation? And let me stretch this and say PAL-B2 also.
So I think since these are all the mutations are in the group of HR deficiency, so I think we should be using this drug particularly in all these cases.
Okay, I think that's very controversial. Dr. Vikas, what do you think in ATM and PAL-B2?
ATM and PAL-B2 mutations are definitely quite common, especially when you go to the molecular pathogenesis of these tumors, and intrinsically they tell us that they are in sort of coming in that pathway, which are the homologous repair deficiency pathway. So they might show that it is intrinsically sensitive to the PARP inhibitors, and when you do that HRR gene panel, the ATM mutations does creep up into it. So I would say that definitely I would give them the if they're affordable, benefit of olaparib. If not, then addition of platinum would definitely be my inclination to go forward to.
Right. So you brought up a point again, a very, very intriguing point. If you saw all the HRD signatures with ATM, if you saw the profound trial from the prostate, the ATM subgroup had no benefit at all. And that's been the problem with ATM. So as we kind of understand more about ATM is very, very tricky. ATM loss, if it is only complete biallelic loss, then probably a PARP may benefit. But otherwise, if it's not a biallelic loss, it may probably not benefit. So it's going to be very, very tricky to offer PARP to ATM mutation. I would kind of say, please be very, very cautious. If don't offer, don't think ATM as a BRCA, and probably keep your BRCA PARP reserved in an ATM. Don't be very enthusiastic about it. Maybe as a late line therapy, when you have nothing to offer, you can try. But there have been a lot of trials which have shown that there's no benefit in ATM when we use PARP. PAL-B2 is again a little bit more tricky. The information is not very clear. So even PAL-B2, be a little careful, but there is a direction maybe PAL-B2 will help. So as of now, if I'm putting in the effort of the money spent, I would probably do it only for a germline BRCA 1 and 2. For the others, I would be a little hesitant doing it. I would probably keep it as a late line when there's nothing else to offer. So I think we're coming to the end. We've seen the recommendations. We've seen what all of us talked about. Second line therapies, yes. So I would like to quite close off, because this is something we'll never end any talk in cancer care these days without immunotherapy. So I would like to close with immunotherapy and take your inputs on that. So Dr. Ashay, what do you think? Any role
So
of
basically, like the not much data really in pancreas. So only thing is that like we have that data where you can try, and those are which are MMR deficient basically tumor. If basically we can have this MSI instability or MMR deficient tumors, but again that proportion is very less. So I mean, actually, I mean, I'm yet to get a patient in pancreas where I can offer immunotherapy actually upfront.
Right, it's very, very rare. Correct. I would agree. So probably that's the right thing. We should look for MMR deficiency, and if we find the MMR deficiency, only then we should be thinking of offering them. Otherwise, we should not offer them. The MSI data clearly is there, but again, it's very, very limited. There are a lot of combinations of immunotherapy which are being looked at in various ways, but again, the results are extremely poor as of now. So probably we should not be offering immunotherapy. I would like to say we we did burn our hands a couple of maybe 1.5 years back or so, doing immuno with various combinations in pancreatic cancers, more as late line settings, but we've not seen any response. And now we are kind of keep chasing it, look for the MMR, and if you have it, only then see it. A quick word of experience sharing about PAP. We've had a wonderful patient who is not our patient originally, but what had been treated for pancreatic malignancy, metastatic disease, had received treatment, had progressed, later found to be BRCA positive. So it was again treated and they got response, and then they started PAP. And it's amazing to see now the patient is following up in Bangalore because their family is here. He's crossed a year of olaparib, which again makes it very encouraging for our patients, because the quality of life is so good. She's off injections, she's on tablets, though there can be issues with it, with PARP inhibitors, but that's something we have learned to manage because we're using it extensively in ovarian cancers. I think with this, I will end the panel discussion. It's been wonderful with getting experiences from all of you, all over India. And all of us have learned how to manage pancreatic cancers in various ways. This, as we say in oncology, it's not about, there's no right and wrong, and that's why we kind of have to manage patients as best as we can in our setting. We work in constraints of the type of patients' affordability, the type of settings we work in. So we learn how to manage best for our patients. So, but I think we should broaden our perspective, that there are always ways which we can expand for our patients, keep looking for newer options. And with this, I thank everyone, and I thank Dr. Naresh for giving me this opportunity. Thank you, everyone, for a wonderful discussion.
Thank you, Dr. Amit, for the wonderful discussion, and to all the esteemed panelists. And I thank to all the previous speakers and those who participated in the various discussions. And with this, I thank once again the sponsors, AstraZeneca and the MedGenome, and the Horizon, Mr. Tarun Mathur, for organizing everything for us. So if no more discussion, I think we should close it here. And I wish that we all stay safe. And we are talking much about the second wave, third wave, this and that. So I pray to the Almighty that we all remain safe, so we can keep continuing sharing our views in the webinar for some more months, if not the whole year ahead. With this, I think we should close it here. Good night to all of you. Thank you. Thank you.
Thank you.
Thank you, Dr. Somani, sir, for all your help and guidance. So thank you so much. Stay safe. Good night from all of us here. So we close the meeting, sir?
Yes, sir. Yes, sir. Close it,
Thank
please.
you. Thank you. Good night, sir. Good night, sir. Good night, sir.